আমার এমনি 2.2 সেকেন্ডস হয়ে গেছে 2 মিনিট 2 সেকেন্ডস না ওখানে ওটা নয় এখানে টাইমার প্লে কর তুই ইন্ট্রোডিউস কর তুই প্লে কর স্টার্ট করছিস মানে start.
Good morning, everyone. Myself, Dr. Soumodip Paria, presenting to you a new kid on the block. A 11-year-old girl presented with complaints of fever for 4 months, generalized weakness and body ache for 3 months, and significant body weight loss in past 3 months. There was no significant past history, no drug history, no history suggestive of autoimmune disease in family, and no history of contact with tuberculosis. On general examination, there was pallor, edema, generalized tenderness including bony tenderness, lymphadenopathy, bilateral inflamed and swollen ankle joint, and generalized peeling of skin. But there was no rash, periangular peeling, oral ulcer, and tonsillar enlargement. On vitals, respiratory rate and pulse rate was slightly higher than the normal. Temperature was raised, BP within normal limit. On systemic examination, on GI, there was hepatosplenomegaly. On CVS examination, S1, S2 was muffled, and respiratory examination and CNS examination was absolutely normal. So, what may be the possibilities? In these settings, the first thing to come to our mind was the malignancies, mainly the leukemia, lymphoma. Second, the infective etiology like HIV, scrub, tuberculosis. And last but not the least, the connective tissue disorders. With all this in mind, we proceeded for investigation. Complete blood count was normal apart from showing hypochromic anemia. There was no abnormal lymphocyte noted in the blood picture. ESR and CRP was raised. Renal function test, liver function test, urine, REME, urine PCR, all were normal. ANA panel, urine culture and blood culture was same. Now imaging, USG whole abdomen and chest showed hepatomegaly with heterogeneous ecotexture, splenomegaly, minimal left-sided pleural effusion and ascites. Echocardiography showed minimal pericardial effusion. Among others, serology was non-reactive, scrub IgM, CVNet for sputum and gastric lavage, torch IgM and IgG was same. The child was started empirically on antibiotics and supportive management. Meanwhile, blood culture report came which showed Pseudomonas species sensitive to piperacillin and tazobactam, and antibiotics were changed. After 3 days of sensitive antibiotics, there was dramatic improvement. Her general well-being improved, generalized tenderness vanished, there was complete remission of fever. Was all this due to sepsis only, or underneath it laid a box of Pandora? We had to explore. But after few days, despite being on sensitive antibiotic, the child deteriorated again. CVNet report came negative. Scrub IgM, torch IgM and IgG was non-reactive. We were standing nowhere. We returned back to the point where we started, the history. While checking her previous prescriptions from outside, we found that she received a short course of steroid a month ago. Was it leukemia? Was the previous picture normal due to steroid? We had lots of unanswered questions. We ordered for a bone marrow aspiration and blood for LDH and uric acid. LDH level was quite high. Was it swing towards malignancy? We had to wait for the BMA report. The BMA report revealed myeloid hyperplasia and only 7% blood cell. No definitive conclusion was drawn in view of receiving steroid from their side. We were stuck in the middle. A repeat CBC revealed much lower hemoglobin count, leukopenia. Was macrophage activation syndrome in vogue? But there was no increase in spleen size, serum ferritin, serum triglyceride, and absolute neutrophil count was normal, possibly ruling out mass. Meanwhile, perioral peeling reappeared in the patient. Fever, weight loss, bicytopenia, generalized tenderness, serositis. Was a connective tissue disorder in vogue? ANA panel showed ANA 3+, anti-SSA, low antibody positive, anti-nucleosome antibody positive, C3, C4 lower than normal, but dsDNA was negative. We concluded our case as systemic lupus erythematosus based on U2019 Euler-ACR criteria, as her score was 20. Minimum score required to classify a disease as SLE is 10. The baby was sought for rheumatologist opinion and started on hydroxychloroquine. Now, here in this case, we used 2019 ACR Euler criteria for diagnosis of SLE. Now, what's new in it? The sensitivity of this criteria has increased to 96.1% compared to 82.8% in ACR criteria. The specificity has increased to 93.4% compared to 83.7% in SLICC criteria. Overall, this classification is much better than the previous one. ANA has been included as an entry criteria. To classify a disease as SLE, ANA positivity is a must. Immunological and clinical criteria are weight-based. If a score is greater than 10, we can classify a disease as SLE. Unexplained fever have been included in the criteria, but if CRP is high, we must rule out infection. Renal biopsy of class 3 and 4 nephritis has been given the maximum points, means 10 points. So if a ANA positive patient have lupus 3 or 4 nephritis in renal histology, is sufficient enough to classify it as a SLE. No other thing is required. And there is scope of omniosity in further studies. That is, the severity of SLE may be classified based on total points, but for this, more studies are required. Now I want to discuss about antinucleosome antibody. Literature have shown that antinucleosome antibody becomes positive much earlier than anti-dsDNA, even before the intramolecular epitope spreads to double-stranded DNA. Few studies have shown antinucleosome antibody is more sensitive and even more specific than anti-dsDNA for diagnosis of SLE. Also, few studies showed that antinucleosome antibody is a better marker for disease activity than anti-dsDNA. But limitations are there. In our study, we have not ruled out Kikuchi disease, brucellosis. Repeat bone marrow aspiration to rule out MASH was not done due to lack of consent. Antinucleosome titer antibody measurement is not possible at our settings. So to monitor disease activity, it is not possible to see for antinucleosome antibody. And most important, leukemia cannot be ruled out in view of receiving steroid. Lots of information to summarize. No steroid should be used before confirming diagnosis in such cases. Even a single dose of steroid can cause lymphopenia, eosinopenia in peripheral blood smear and neutropenia. And a short course of steroid can cause change in both bone marrow and PBS picture. So 2019 Euler-ACR criteria can be used for pediatric and juvenile SLE as well as confirmed by British Rheumatology. Antinucleosome antibody can come up a new diagnostic tool criteria for SLE, and gram-negative bacteriological coverage, including Pseudomonas, is indeed needed in cases of SLE with concomitant infection. Thank you. No, sir. No, ma'am. Her just the generalized tenderness vanished, and as a whole, the child was very sick, very irritable. That improved, but the arthritis was, then the regression of spleen or liver was not seen. Ma'am, I cannot hear it. It's very echoing, but I'm not hearing. Ma'am, please can you? Yes. Yes, sir. CRP was raised. Now can I go forward? I cannot hear your question. Means it's echoing. Sir, ma'am, ESI and CRP, the CRP reduced, but the ESI didn't reduce. The CRP was reduced. ESI remained the same. So, ma'am, I think the child should be treated with hydroxychloroquine plus a corticosteroid. Sir, actually, we are going by the experiments. One by one, we are excluding. The previous picture came normal. The BMA was normal. So we were only left with connective tissue disorder. Amish, sir, can I come forward? I cannot hear.
Thank you.
Thank you.
Can I invite the next speaker?
এখানে নিলাম শেয়ার স্ক্রিন নিলাম এটাতে দিলাম শেয়ার করে দিলাম এটা এখানে দিয়ে দিলাম
Good morning, everyone. I am Dr. Arpa Karmakar from Medical College, Kolkata. This is an 11-year-old girl who had born out of non-consanguineous marriage with uneventful birth and past history and with normal developmental milestones. The girl had presented with history of fever, which was low to moderate grade and irregular for the past 1.5 months. There was a history of gradual weight loss for the past 1.5 months and weakness of both the lower limbs for the past 1 week. She also had drowsiness for the past 3 days. However, there was no history of any rash, bleeding manifestations, convulsions, headache, vomiting, any visual or auditory complaints. There was no history of any TB contact. On examination, the child was found to be drowsy. There was mild pallor. The vitals were stable. However, the child had fever. There was generalized lymphadenopathy, including bilateral, cervical, and axillary lymph nodes, about 1.5 centimeter, non-matted, non-tender, and firm in nature. There were no bleeding manifestations or no rash. So we went for the systemic examination, and this child had presented with drowsiness, weakness of both lower limbs. So we first examined the nervous system. As far as the higher mental functions and mental status is concerned, the GCS was 10/15. She was not oriented to time, place, and person and was speaking inappropriate words. Cranial nerve examination was absolutely normal, and there were no meningeal signs. Sensory examination of the sensory system could reveal presence of pain sensation only. The rest part could not be assessed properly because of drowsiness, and there were no autonomic instabilities. Cerebellar signs were absent, and examination of skull and spine did not reveal any abnormality. Examination of the motor system showed the upper limb to be in a flexed attitude. The lower limb was lying helplessly in externally rotated position. There was wasting in both the upper and the lower limbs. No abnormal movements were there. The tone was increased in both the upper limbs, while it was decreased in both the lower limbs. The power was 3/5 in both the upper limbs. It was 2/5 in both the lower limbs. The jerks were exaggerated in both the upper limbs, and it was absent in both the lower limbs. There was no bilateral, there was no plantar response reflex found bilaterally. Examination of the other systems did not reveal any other abnormality. So we went for the investigations. So we have this complete hemogram which showed bicytopenia, and peripheral blood smear showed no evidence of any blast cell. The liver function test showed transaminitis. The ESR and CRP were raised. The serology was non-reactive. The mass profile was negative. The blood culture was negative. We went for the lumbar puncture, which showed albuminocytological dissociation. The protein level was raised without any increase in the cell count. The cell count was only 4. Nerve conduction velocity showed axonal type of motor neuropathy in both the lower limbs. Radiology revealed normal chest X-ray and normal ultrasonography of the whole abdomen. This is the MRI brain T2 flare image, which shows hyperintensity in both the bilateral, putaminal, and periventricular regions, and this is suggestive of acute demyelination. So we have this 11-year-old girl who has presented with altered sensorium. There are features of upper motor neuron lesion in the upper limb and lower motor neuron lesion in the lower limb. The nerve conduction velocity is suggesting axonal type of motor neuropathy, whereas MRI brain is suggestive of demyelination. So our diagnosis at this stage is acute demyelinating encephalomyelitis with polyradicular neuropathy. So this child has presented with dual pathology. There is demyelinating lesion along with polyradicular neuropathy. To cover up for both, we started the child on IVIG, which was given at the rate 1 gram per kg for 2 days. So there are multiple case reports of presence of both acute disseminated encephalomyelitis with the polyradicular neuropathy, and this case report supports that post-infectious inflammatory diseases of the nervous system can include both the central and the peripheral nervous system simultaneously. And in such cases, there are other case reports which suggest that corticosteroids, high dose IVIG, and plasmapheresis, they play an important role in the therapy. But we had this child also had fever, lymphadenopathy, and significant weight loss. So we needed further investigations to look for the possible underlying etiology. So we went for the infectious causes, and we again found persistent bicytopenia. Common infections in the serum and CSF were ruled out. Tuberculosis, which was an important differential, was also ruled out. We also looked for the autoimmune encephalitis panel, and it came to be negative. Malignancy is another possibility. So we went for the lymph node FNAC, which showed presence of atypical lymphocytes. However, no features of malignancy were found. Lymph node biopsy also ruled out any evidence of granuloma or malignant cells. Bone marrow study was within normal limits. And this is the image showing the atypical lymphocyte which we found in the FNAC of the lymph node. So, based on the history and the investigations, one of the provisional diagnosis was infectious mononucleosis, because this patient was having generalized lymphadenopathy without any organomegaly, bicytopenia with the abnormal liver function test, and FNAC had showed evidence of atypical lymphocytes. So to confirm our diagnosis, we went for the Epstein-Barr virus viral capsid antigen antibodies. The IgM came out to be negative. However, the IgG was raised and the titer was 120 units per ml. So the complete diagnosis is acute demyelinating encephalomyelitis, polyradicular neuropathy in a case of Epstein-Barr virus infection. So if we talk about infectious mononucleosis, although not very common, but there are case reports of acute disseminated encephalomyelitis following Epstein-Barr virus infection. The incidence of neurological complications is very less. It is less than 1% in case of infectious mononucleosis, but they are a very important cause of death in case of Epstein-Barr virus infection. This is another case report of acute disseminated encephalomyelitis following Epstein-Barr virus infection. And this child did not respond very much to IVIG and methylprednisolone, but the child responded well to rituximab. So for the hospital course, so after we had given IVIG, the sensorium had improved in the next 2 to 3 days. However, weakness persisted. It took 1 week for the power of the lower limbs to improve, and this was followed by the normalization of jerks. The patient could properly walk at the end of 2 weeks, and the Glasgow outcome score at discharge was 5. MRI brain was done after 3 months, and it has shown resolution of the previously noted hyperintensities. So my take-home message is that post-infectious neurological complications may involve both CNS and PNS simultaneously, and the presentation may be varied, like dual pathology. Thank you. So post-infectious neurological complications may involve the central and the peripheral nervous system simultaneously, and it is the continuum which may range from acute demyelination to polyradiculoneuropathy. The presentation can be varied, such as in this case, we had upper motor neural lesion in the upper limb and the lower motor neural lesion in lower limb, which suggests presence of dual pathology. And whenever possible, we should always look for the underlying cause of the demyelination and polyradiculoneuropathy. Thank you.
Thank you for your presentation.
Positive.
Infection which is there in the past. So why the identification by PCR was not done? And also against your diagnosis, in initial when patients are active state of condition, there is no lymphocytosis, no abnormal lymphocyte. So when normal lymphocyte is of infection, subsequently so that there is identification.
So probably this patient had presented very late. The patient had presented after a prolonged history of 1.5 months. So that is why probably we could not get all the features we get in a typical acute infectious mononucleosis.
Okay, and did you do the EMG and all? Insinuation, exercise, what are the upper limbs?
Upper limbs NCP was normal.
Again, I mean, said this is a clear representation of the sequence. How can I explain the bicep here? What is the cause of that?
Probably there was some underlying infection also, which might have led to the bicytopenia. We did all the relevant investigations like ruling out malignancy, HLH, but we could not actually explain this. Thank you.
Next one. So may I invite the next speaker, Andrew Shamu.
Good morning, everyone. I am Dr. Atul Shamantul from CMRI Hospital, and today I am going to discuss about cystic mystery. So, a preterm male child born due to an IVF pregnancy, first among the twin, has been delivered by a lower uterine cesarean section at the period of gestation of 31 weeks. After birth, we had observed the child had poor respiratory efforts. His heart rate was less than 100 per minute, hence required positive pressure ventilation by bag and mask for 30 seconds. After positive pressure ventilation, his heart rate improved to more than 100, spontaneous respiratory efforts regained. Apgar score calculated for 6 in 1 minute and 7 in 5 minutes. But soon after, child had developed audible grunting with tachypnea and bilateral retractions. Hence, the child was transferred to NICU and connected to nasal CPAP. The birth weight was calculated there was 1.76 kgs. At the NICU, we had done chest X-ray, which revealed bilaterally low lung volume along with ground glass opacities. Hence, respiratory distress syndrome was suspected, for which the child was given nasal surfactant by insure technique, reconnected to CPAP, and as the child improved gradually, he was weaned off. While being weaned off, nasogastric feeding was started and gradually being increased. And while we increased the feeding, we had observed that the child had developed an epigastric distension, for which we had done an X-ray abdomen. The X-ray abdomen revealed, as we can show in the picture, that there is a distended bowel loops, but there's no features of air fluid levels or gas under diaphragm. We had done a sepsis screen, which was negative. Next step, we had done an USG whole abdomen, but the USG whole abdomen also ruled out congenital hypertrophic pyloric stenosis, short distended bowel loops, but did not give any conclusive evidence. Hence, we had done an upper GI contrast study considering an upper GI obstruction. So, an water-soluble gastrographic contrast study was done, which clearly showing that the contrast material is filling inside the gastric lumen, but also spilling outside the stomach likely at a large cystic outpouching at the right side of the stomach. Hence, to locate the exact pathology, we had done a CT scan of abdomen, which clearly showing that there is a large cyst communicating with the gastric lumen at the right side of the gastric lumen. So what we have got till now, a 31-week preterm resulted to an IVF pregnancy, first among the twin, requiring positive pressure ventilation after birth, diagnosed with respiratory distress syndrome, for which requiring surfactant administration and CPAP support. Sepsis screen was negative, and while feeding was started, developed an epigastric distension, for which an X-ray abdomen was done, which showed distended bowel loops, but no presence of air fluid levels or gas under diaphragm. Hence, an water-soluble gastrographic contrast study was done, which revealed that the spilling of the contrast material at large cystic outpouching. Hence, to confirm the position of the abnormality, a CT scan of abdomen was done, which showed a cystic outpouching at the right side of the stomach, communicating with the gastric lumen. Hence, our provisional diagnosis was duplication cyst of stomach. As the mainstay treatment for duplication cyst of stomach is surgical resection, we had planned a laparotomy, and laparotomy revealed a large cyst communicating with the stomach at the lesser curvature. The cyst was being supplied by the right and left gastric arteries, similar blood supply as the lesser curvature of the stomach. The cyst was completely resected and the margins of the stomach was opposed, and the specimen was sent for histopathology. So here are some pictures from the laparotomy. In the first picture, we can see that there is a cyst and the inner lining of the stomach was visible, and some portion of the healthy bowel loops are also visible. In the second picture, we can see the gastric lumen and the cyst. And in the last picture, we see that the entire cyst margin was resected and the margin of the stomach is opposed. The histopathology revealed that there is a congested edematous cyst wall, and the inner lining of the gastric foveolar epithelium was visible with gastric foveolar cells and gastric mucosal epithelium, gastric mucosal glands. The outer smooth muscle coat is also visible with muscularis propria layer, muscularis mucosa layer, and the submucosa. Hence, our diagnosis was confirmed as a gastric duplication cyst. The child was kept nil per oral till day 6 postoperatively. Child remained clinically and hemodynamically stable. On postoperative day 6, a repeat contrast study was done, which showed there's no presence of any obstruction. The contrast material was passing through the stomach smoothly into the duodenum. Hence, nasogastric tube feeding was restarted, which was gradually being increased. And when bull feed was established, the child was transferred to oral feed. But on day 15 of life, child developed lethargy and infrequent apnea. Sepsis was suspected. Blood investigations revealed a positive sepsis screen with culture showing a positive growth of Acinetobacter baumannii, which was sensitive to IV meropenem. As CSF was negative, the IV antibiotic was continued for a total 14 days. And as the child remained clinically and hemodynamically stable, full feed was established orally. Child is gradually being discharged. Hence, some slides about gastric duplication cyst. GI tract duplication or enteric duplication occurs in 1 in 4,500 live births, among which gastric duplication occurs only in 2 to 7%, that is 17 in 1 lakh population as per literature. Features of GI obstruction are common in neonates like feed intolerance and epigastric distension. And in older children and adults, recurrent vomiting, abdominal pain, rectal bleeding, and some other non-specific GI symptoms have also been observed. Even in adults, it also found incidentally, and the patient remains asymptomatic. 95% of the cyst occurs along the greater curvature of the stomach, and only 5% is seen along the lesser curvature, like in our baby. There is a specific diagnostic criteria for gastric duplication cyst, which includes, firstly, that the cyst wall is to be contiguous with the gastric wall. It is to be surrounded by a layer of smooth muscle, which is continuous with the gastric muscle. The cyst and the stomach should share a common blood supply, and the cyst must be lined by any type of epithelium of GI tract. All those criteria fulfilled in our baby, hence our diagnosis of gastric duplication cyst was confirmed. 80% of the cysts are cystic or non-communicating type, and rest 20% are tubular or communicating type, like in our baby. There may be also presence of ectopic tissues like duodenal, pancreatic, or respiratory tissues, where presence of pancreatic tissue can also mimic pseudocyst of pancreas. There is a significant risk of malignant transformation, and adenocarcinoma is being reported mostly among those malignancies, while neuroendocrine carcinoma and small squamous cell carcinoma are seen but being reported less frequently. Hence, surgical resection of the entire cyst wall is the mainstay treatment of choice. So the take-home messages: firstly, gastric duplication is a rare congenital anomaly which should be suspected in neonates with features of gastrointestinal obstruction with other commoner pathologies like duodenal atresia, duodenal wave, jejunal or ileal atresia, or congenital hypertrophic pyelodystenosis. As there is a significant potential of future malignancy, early surgical resection of the entire cyst wall is the treatment of choice. And lastly, radiology can provide a supportive evidence by confirming the presence of cystic mass at the stomach, but histopathological examination of the resected specimen always confirms the diagnosis. Thank you.
Dr. Shah, this is a nice presentation, and this also one of the realist case. And did you follow up with that child?
Ma'am, actually, follow-up is planned. It is a very recent case, 1 month ago. To after that, child didn't come to follow-up, but a follow-up is planned.
What is the prognosis of this?
Ma'am, we have to see till now, and
This patient has duplication of the smaller curvature. What is the prognosis?
ma'am, actually, it is very rarely reported in the lesser curvature, but there is in future, actually, in some other cases, we have seen that also if the margin was not resected properly, there is also development of carcinoma which has been reported previously.
So, my query is, what made you cut the decision? What was made cooperative as soon as possible? Because it also integration mentioned that sometimes diagnosis later on. So why the surgical on baby weight was 90 and that type of operations? What is the weight of the child?
The weight was 1.76 kg.
Why it was operated alternately the situation?
So firstly, as I also mentioned in the take-home messages, that previously reported cases and the prognostically, as it has a significant risk of malignancy, early diagnosis and early resection. This is the mainstay treatment of choice. Hence, and also if we do not operate that properly, if we do not remove that pathology, then that feed intolerance and these things will never be resolved. Hence, considering the risk of malignancy and considering this obstructive pathology, we have decided to operate the baby.
Ajit, you said there were 6 post-operative days before you could treat the child.
Yes.
So can you talk a little bit about how you provided infection policy for the child?
Ma'am, TB,
Infection also may be a risk factor.
as the child remained hemodynamically stable after operation, we had provided TPA. We had given aminoven, GI was calculated as per dextrose was given, and also lipid was provided. So after that, we had decided to go for an upper GI contrast, and seeing that there was no further obstruction, we had decided to start injecting.
So I invite the next speaker, Dr. Audrey, to come and present this.
Good morning, all the delegates and dignitaries. Myself, Dr. Auditro from Dr. B.C. Roy PGIPS. I am going to present my case, that is Sinovac with anti-GABAB encephalitis in NRROS mutation, first reported case worldwide. The boy whose case it is, that is a second-born boy born out of a second-degree consanguineous marriage who had normal developmental milestone till 6 months, as evident from the picture. Now the boy presented to us at 1.5 years of age with multifocal and generalized myoclonic charts. There was no evidence of fever. At presentation, his occipitofrontal circumference was 46 centimeter, plotting which we got Z-score within -1 and -2 standard deviation of WHO growth chart. Initially, he had appendicular and axial hypotonia, followed by appearance of appendicular hypertonia over next 3 months, with deep tendon reflexes and bilateral extension plantar reflexes. There was absence of any neurocutaneous marker, no organomegaly, no abnormal body or urinary odor was found. There was no family history of epilepsy. Now coming to the evolution of the seizure, at 7 months, first episode of febrile status epilepticus was developed. Then the baby started having recurrent episode of complex febrile seizure. At 9 months, the baby started having afebrile GTCS, which developed into myoclonic jerks occurring in clusters. Then the appearance of clonic jerks was found, and the seizure progressed in frequency and severity, resulting into global developmental neuroregression. Now, this is a short video clip showing the myoclonic jerks of the baby. Now the baby was treated with multiple anti-epileptic drugs such as levetiracetam, clobazam, and valproate. Despite that, seizure was not controlled, and subsequently the baby developed decorticated posturing. This is a picture of that. Coming to the investigations, all the investigations we yielded no obvious abnormality except the CSF autoimmune panel, which was positive for anti-GABAB antibody. Now we did the neuroimaging NCCT brain, which revealed diffuse brain calcification, diffuse brain atrophy with punctated scattered calcification as shown by the yellow arrow, predominantly in the subcortical white matter. MRI brain T1 sequencing, the axial section shows 3 things. The first thing, which was pointed by the green arrow, that is the subcortical atrophy. Now coming to the yellow arrow, which shows the relative cerebellar sparing. And the most important finding, that is the pink arrow, which shows the greater dilatation of the left occipital horn compared to the right side. Now again the same picture in the coronal section. The yellow arrow is pointing towards the predominant bilateral frontal atrophy, and the red arrow shows the same thing, that is the temporal atrophy with asymmetrical dilatation, right more than left. Now the next investigation, that is sleep EEG, which showed bilateral frontotemporal high amplitude spike and sharp weight discharge with progression to showing generalized epileptiform discharges. In the background of anti-GABAB antibody positivity, which is also a rare phenomenon, only 3 cases have been reported in children worldwide. The baby was started on pulse IV methylprednisolone at 30 mg per kg per day for 5 days and IVIG at 2 gram per kg. Seizure frequency decreased drastically over next 1 month. The baby was discharged on tapering dose of oral prednisolone with valproate, levetiracetam, and clonazepam. But the baby was planned for monthly IVIG regimen. Next generation sequencing of whole exome was planned. This is the interesting part. That is, the exome sequencing reveals an autosomal recessive homozygous biallelic variation located on the exon 3 of the NRROS gene. This is the picture of the mother and the father showing the same sequencing validated by the Sanger sequencing. Hence, the baby is diagnosed as a case of infantile onset encephalopathy, known as early onset seizure with neurodegeneration and brain and calcification. That is the CME, resulting from homozygous biallelic nonsense mutation of NRROS gene. The baby is still under follow-up for last 8 months, receiving 7 cycles of monthly IVIG pulses. The baby is on now 0.5 mg per kg per day oral prednisolone and has been started on ketogenic diet. Repeat CSF autoimmune profile was done on 3rd and 6th month after discharge, which was negative for anti-GABAB antibody. Patient is now seizure-free, but significantly disabled in decortication without any speech output and visual following. On the contrary of the admission OFC, that is 46 centimeter, now the baby has developed more shrinkage of brain, that is OFC pointing towards 44 centimeter, Z-score being less than -3 standard deviation. This is the follow-up EEG, which shows disappearance of the epileptiform discharges, but still lacking the normal sleep pattern. Now the discussion. Microglial function is the mainstay of this part. That is CSF1R, DAP12, TYRO-BP, TREM2, ESP18, and IRF8. These are the genes which have been noted for microglial function. Noved et al. In 2014 first discovered the NRROS gene, which is present on transmembrane protein of endoplasmic reticulum containing leucine-rich repeats, which regulates the reactive oxygen species generation by 3 mechanisms such as NADPH oxidase 2 degradation, toll-like receptor signaling, and activation of TGF-beta pathway. The important thing is, in mice experiment, NRROS deficient phagocytes exhibited elevated ROS production, causing ROS damage, causing fatal autoimmune encephalomyelitis. Now, this is the 11th case report of NRROS mutation related to CME worldwide, but first one to trigger anti-GABAB positivity. This is the table where all the authors are written and all the genetic variations noted are written along with the types of mutation. The yellow arrow points towards our type of mutation, that is a protein truncation at 496 amino acid, resulting more than 10% loss of protein function. All the authors are Smith et al., Dong et al., and McIntosh et al. Have described 10 other cases. So what our case adds? This is the first case report of autoimmune encephalitis associated with CME, which was reported only in mice experiments till now. None of the previous authors have described the treatment modality based on our experience shared. Above, immunomodulation can be a possible approach to treat the CME. It adds another novel NRROS variation to the recently evolving genetic conundrum of CME. So, this Independence Day, CME comes to India. Thank you.
So it is a simply genetic encephalopathy.
Genetic epilepsy.
Yes.
Genetic epilepsy.
In epileptic encephalopathy, not only epilepsy, it is genetic encephalopathy, where there is non-specific discovered the variable. But how do you judge how long will be the IPIG? Is it because
Actually,
monthly? So how did you continue?
Actually, ma'am, we have searched through all the case reports previously described. Among the Ukrainian case reports and the Romanian case reports, they haven't proposed any treatment. They have gone with only methylprednisolone, and all of them died within 3 years. Only the eldest one alive till 9 years of age, and he is receiving monthly IVIG in one patient. So we are going with that only. And we started the treatment based on anti-GABA-B encephalitis, which is also a rare entity. Yeah, we did the CSF autoimmune panel. It only showed GABA-B positivity. Rest all of were negative.
What will be this particular patient?
Actually, sir, the patient was first going to be treated was like a seizure disorder on the regular basis in a OPD basis. And the seizure was continuously evolving from one nature to another nature. So we first started, maybe this is a case of autoimmune encephalitis. When we got a case of anti-GABA-B encephalitis, we were not convinced that only 3 such cases are reported in the world. So maybe there is something more to it. So we went for a genetic sequencing and we revealed the genetic evidence. Yes, yes. In the first slide, I showed that the baby was born out of consanguineous marriage. That's why it is autosomal recessive inheritance. Thank you.
May I invite the next speaker, Dr. Bondhu Gopal Shah.
Good morning, everyone. I am Dr. Bondhu Gopal Shah. Today, I am going to present a case of neonatal thrombocytopenia. A 2-month, 10 days old male baby presented with persistent low platelet count from the 3rd day of birth, with multiple bruises in both legs. On birth history, he was a firstborn male baby delivered preterm on 35-week 1 days via lower uterine cesarean section and due to antepartum hemorrhage. The birth weight was 2.125 kg, which is appropriate for gestational age. The baby cried immediately after birth and no history of inadvertent bleeding at the time of birth. On family history, no history of consanguinity, no history of abortion, and no history of bleeding disorder among the family members. This is the course of the disease before admission at ICH. On day 3, the baby was incidentally detected with low platelet count and the count was 50,000. On day 14, the baby developed periorbital puffiness, multiple petechial spots in both lower limb. On day 22, multiple episode of tinge of blood was coming with stool and vomitus, and the baby got admitted in outside hospital, and there 3 unit platelet and 1 unit PRBC transfusion was given. On 1 month, 8 days, intravenous immunoglobulin is infused at the rate of 1 gram per kg. At the age of 1 month, 23 days, blood culture showed growth of Acinetobacter and Piperacillin tazobactam. Amikacin started and later upgraded to meropenem. On 1 month, 28 days, valganciclovir was started as urine CME PCR was positive, but could not be continued as platelet count was falling. This is the investigation chart done outside, which showed persistent low platelet count, and lowest notable platelet count was 14,000, and there is elevated CRP multiple times. The outside investigation also showed PT, APTT, INR normal, TORCH screening was negative except CMV IgG was positive, urine CMV PCR was positive, serum G6PD level was normal, thyroid profile was normal, and LFT was normal. At the age of 2 months, 10 days, the baby was referred at ICH, and the initial blood count showed platelet count 34,000 and CRP was 43. On clinical examination, baby was alert, active, afebrile, no facial dysmorphism was present, multiple ecchymotic spots in bilateral lower lip, and multiple skin rashes was present at back, scalp, and arms and shoulder, which was likely to be seborrheic dermatitis or eczema. On clinical examination also showed hepatosplenomegaly, and radius was present, and normal rotational movement at radio-ulnar joint, and no cataract was found in eyes. Peripheral blood smear report showed diminished platelet count, and all the parameters was all the parameters normal. And notable point is mean platelet volume was 10 femtoliter, which is normal range. Bone marrow aspiration biopsy showed megakaryocytic thrombocytopenia and erythroid hyperplasia. Others investigation showed mother's and father's platelet count was normal. As we all know, in autoimmune thrombocytopenia, both mother and baby have low platelet count. And HPA genotyping showed no incompatibility among the family members, which exclude alloimmune thrombocytopenia. On other checkup, USG brain showed normal. As we all know, intracerebral hemorrhage is a complication of neonatal thrombocytopenia. Echo was normal, hearing screening was normal, and eye checkup was normal. No cataract was found. And on skin examination, multiple eczema-like rashes was found in back, scalp, and upper part of arms and shoulders. Treatment at ICH, injection ceftriaxone and 3-unit platelet transfusion was given. On discharge, baby was hemodynamically stable and blood count showed platelet count 69,000 and CRP was 11. The baby was on regular follow-up with weekly CBC report. At the age of 4 months, 10 days, the baby got readmitted, and at the time of readmission, no hepatosplenomegaly was found. And injection ceftriaxone and 2-unit platelet transfusion was given. This is the blood count of serial follow-up, which showed persistent low platelet count, and CRP was again elevated. On differential diagnosis, we can rule out sepsis. The baby was not sick, and he was a well baby. Necrotizing enterocolitis was ruled out as platelet count was low for more than 4 months, and the baby was not very sick. No history of any drug causing thrombocytopenia was found except valganciclovir and meropenem. We stopped both of the drugs, but thrombocytopenia was not improved. Congenital megakaryocytic thrombocytopenia ruled out in bone marrow report. Neonatal alloimmune thrombocytopenia ruled out in a HPA genotyping report. Autoimmune thrombocytopenia ruled out as mother's platelet count was normal. TORCH screening was normal. Atras and TAR syndrome. Megakaryocytic thrombocytopenia with radioulnar synostosis and thrombocytopenia with absent radius was ruled out as radius was present and normal rotational movement at radioulnar joint. Inward error of metabolism also ruled out as baby thrombocytopenia was persisting and baby was not very sick. We were left out with Wiskott-Aldrich syndrome. This is a table diagram showing the approach to diagnose late onset thrombocytopenia, which I discussed earlier. Next, we proceeded for whole exome sequencing, which showed was gene positive at the location of intron 10 and X-linked recessive inheritance hemizygous, which concludes our diagnosis to Wiskott-Aldrich syndrome, which is a triad of thrombocytopenia, recurrent infection, and eczema. All of the three was present in our baby. The notable point is in Wiskott-Aldrich syndrome, we usually found low volume platelet, but in our case, platelet volume was normal. We are further planning for investigation was protein screening and serum immunoglobulin levels. And in serum immunoglobulin levels, we all know in Wiskott-Aldrich serum IgE and IgA level is elevated, and this is the conclusion of my presentation. Wiskott-Aldrich syndrome. Actually, the baby came to us at 2 months, 10 days age, but the valganciclovir was started outside before admission at ICH. So probably they, after getting the urine CME PCR report and the the report mentioned 20,000 copies. So maybe thinking of that, they started Valgan cyclopedy.
Okay, so what issue is with the customer? Did you go for the original band? Did you go for that?
No, the baby is just few days back, he was diagnosed. So we are planning for further investigation after the consent of the parents.
So what will be the next modality of treatment?
Bone marrow transplant.
In when you have done your literature study, what is the general prognosis with this condition?
Even after the stem cell transplant, the prognosis is not very good because it is a T cell lineage immunodeficiency disorder. So multiple episodes of infections and maybe persist in future, and prognosis is not very good.
Thank you.
So I invite the next speaker, Dr. Shomodip Sharma.
I will present a atypical case of anasarca in a patient of vision loss. I am Dr. Shomodip Sharma. The patient is an 11-year-old, 9-month female child, informant being the mother, presented to us with a dimness of vision in the right eye for a period of 2.5 years and swelling of body since 6 months. The history dates back to 2019 when the patient had a sudden onset loss of vision in the right eye with loss of perception of right. This was not associated with any other neurodeficit. In 2021, the patient again had a sudden onset loss of vision with loss of perception of light. The patient developed sudden onset weakness of the lower limb that progressed to the upper limb, along with urinary retention and bowel dysfunction. No evidence of encephalopathy were present during this episode. The patient presented to us with anasarca for a period of 6 months that progressed from face to abdomen and the lower limbs that was associated with loose stool, watery inconsistency. No evidence of hematuria, dyspnea, or icterus was present. The treatment history revealed that patient had received prednisolone for a period of 1 month in 2019 for the vision loss and also for a period of 3 months for the neurological deficit in 2021. The other history were all normal. The nutritional history was adequate and the staple diet for the patient was rice. So from history we derive that this is an 11-year-old female child with two neurological events, each time being associated with vision loss, with the second episode being associated with quadriparesis followed by apparent recovery. The patient had generalized edema at admission. So we went for the examination. The general examination revealed generalized edema, which was pitting in nature. Anthropometry revealed a short stature, a stunting. The bone age was calculated, and by that we derived that height age was less than bone age, less than chronological age, which was suggestive of a chronic disease. The rest of the examination, abdominal examination and respiratory system examination, revealed ascites and bilateral pleural effusion, respectively. The central nervous system examination was done, which revealed a visual acuity of 6/60 in the right eye and 6/6 in the left eye. The pupil of the right eye showed a relative afferent pupillary defect. The rest of the CNS examination were all normal. So from CNS examination, we derive that the patient only had a dimness of vision in the right eye with otherwise normal neurological examination. So from summary of history and examination, we had two different events. One, a neurological event that had a dimness of vision in the right eye with latter episode having a myelitis-like presentation that was being treated outside with a presumptive recovery, but the vision disturbance was still persisting in the right eye. And the patient also had anasarca for a period of 6 months along with stunting. So are we dealing with a single pathology or a multiple etiologies? So keeping this in mind, we went for the investigations.
First, as the patient presented with anasarca, we went for the urine examination, which were absolutely normal, and nephrotic syndrome was ruled out. The complete blood count was done that revealed a mild anemia with macrocytosis. We went for hypersegmented neutrophil, but was absent. The LFT was done. The liver function was absolutely normal, except hypoalbuminemia. No alteration of liver enzyme was present. PTINR was normal. The markers for the chronic liver disease, ceruloplasmin and autoimmune liver profile were all negative. The kidney function test and electrolytes were done, all were negative. The cholesterol and triglyceride revealed hypertriglyceridemia along with hypercholesterolemia. The investigation for collagen vascular disease was done because it was revealing a multi-system disease, but were all normal. We ruled out tuberculosis, and then we investigated for the vision loss. The MRI spine revealed a patchy demyelination up to D7 vertebra. MRI brain were normal, orbit were normal. NMO MOG antibody were sent, and the report was awaited. VP were normal, oligoclonal band was sent from CSF. The report was awaited. The previous MRI of the patient during the myelitis-like episode was traced that showed extensive demyelination, long segment demyelination from lower medulla to the D7 level of the spinal cord. So now we are at a stage of anasarca without proteinuria, having severe hypoalbuminemia and hyperlipidemia, and multi-system causes of collagen vascular disease, abdominal tuberculosis, and malignancy were ruled out. Then we had to approach for the other cause of loss of protein, that is protein losing enteropathy. And being intestinal lymphangiectasia as a very common cause of protein losing enteropathy, we went for upper GI endoscopy, which showed a erythematous mucosa of the stomach, and we took a biopsy from the D2 and D1 segment from the duodenum. That revealed a peculiar image of villus atrophy, crypt hyperplasia, and intraepithelial lymphocytes that were suggestive of celiac disease. We staged the disease, and that was MARS3A, almost confirmatory histology of celiac disease. So we went for celiac disease, but surprisingly, the anti-TTGA, IgA were negative, being IgA being normal. Then as per the algorithm of Isfahan, we went for the look for false negative causes. Does the patient was on immunosuppressant? The answer was yes. Does the patient was on a minimal gluten diet? The answer was again yes. And the extraintestinal manifestation were more than that of the intestinal manifestation. So we had to go for HLA, and the HLA was sent, and the report is still pending. The patient was started on a gluten-free diet. The systemic other autoimmune diseases that are associated with celiac were ruled out. As the reports are pending, we went for ICTC and IgM, IgG, and IgA to rule out HIV and CVID, that this may also cause villus atrophy. The course of the hospital stay, the patient required 60 minutes albumin, and after starting the gluten-free diet, the edema subsided, albumin requirement decreased, and the albumin started rising. The vision problems were still persisting, and aquaporin 4 and MOG antibody reports are pending. So, are we dealing a case of celiac disease having a spectrum of extraintestinal manifestation of demyelination and an intestinal manifestation of protein losing enteropathy? And so with the gluten-free diet was our mainstay of treatment, but there was a twist in the tail. The patient again developed a right eye dimness of vision with a resolving edema. Even with resolving edema, even on gluten-free diet, which were managed aggressively by methylprednisolone followed by IVIG and mycophenolate mofetil. Meanwhile, we received the investigation. The investigation revealed aquaporin 4 positive with OCB being negative. MRI revealed of orbit, that is retrobulbar neuritis. VP showed increased latency suggestive of optic neuritis. So the neurological event was a case of neuromyelitis optica spectrum disorder with optic neuritis and acute myelitis at the core feature with aquaporin 4 positivity. The patient was discharged hemodynamically stable state with 6/36 vision in the right eye, that is improving from the time of admission on prednisolone and MMF. Folic acid was added and gluten-free diet is continued. Since the HLA report is pending, but MARS is almost confirmatory, we suggest that this can be also a case of HLA DQ2 positive. We will go for celiac disease. If it is HLA DQ2 and DQ8 is negative, we will consider a non-celiac gluten sensitive enteropathy, and autoimmune enteropathy is another possibility that we keep in mind. So our main question to the house is that NMOSD and autoimmune enteropathy, is it a mere association or a spectrum of same disease? Now, this is how we want to follow up the patient. If the CNS manifestation also resolves with the gluten-free diet, and we can show that the patient is on without immunosuppressant, the patient is doing very well, then this will be a case of gluten-induced demyelination and enteropathy only. Since we have our HLA report pending, we have also planned for an whole exome sequencing to rule out immune dysregulation. Thank you.
Thank you, Shamu. Grace. The first thing when you talk is, and there's a spine for involvement, the very beginning is an emergency, and this is the so it is clear that case of emergency one part. The second one is as you already said, chronic laryngeal is very is and high is according to respectively decrease. So it is a chronic chronic disease, and first thing we will know about the severe disease. So and it is a very common thing. The severe disease can have a elements. Is a correlation?
Yes, ma'am. Multiple literatures have been searched for this. And then the association of aquaporin 4 positive in a patient of celiac disease is a very frequent association. But celiac disease itself is associated with multiple autoimmune etiology, of which a demyelinating CNS disorder is another manifestation. So the question that remains in our case is if NMOSD, the patient having NMOSD, that is aquaporin 4 positivity, they are showing multiple cases of celiac is having aquaporin 4 positive. But celiac is itself a case of demyelinating disorder. But the question that remains is those demyelinating disorder, whether are these NMOSD and those demyelinating disorders same, or aquaporin 4 positive patient is a separate entity that because celiac is associated with multiple autoimmune etiologies.
Yes.
So that may be another manifestation. Now, another interesting point that I want to highlight in this case is that these patients, multiple case report that showed that when the anti-TTG antibody is rising, then the optic neuritis part is also rising. So there may be a correlation, and further research is also yes. Sir, actually, sir, first of all, the patient was treated in a peripheral medical college. The patient was actually treated the first episode, that was only a case of optic neuritis, was actually treated by the ophthalmology department only and received a course of steroid for 1 month. The second episode was a case of myelitis and with optic neuritis, which was treated by a short course of steroid, but the evaluation was incomplete. That's the first part. And the second part is that the patient, when came to us, had 6/60 vision in their right eye, but the mother told that this vision is persisting for a period of almost 1 year. So we didn't go for aggressive treatment at first and went for the evaluation first. But then what happened was that we got a picture of celiac disease and thought that this will be an extraintestinal manifestation of celiac and went for gluten-free diet as our mainstay therapy. But what happened was that in spite of gluten-free diet for 4 weeks, the patient again developed a dimness of vision with loss of perception of light. Meanwhile, we got the aquaporin 4 positive report and this made us to think that it may be a separate entity and celiac may be a separate entity. So we went for aggressive treatment, which revealed that there was and the patient showed a remarkable improvement. And the vision at admission was 6/60, at discharge was 6/36. So we are confident that the patient will improve in due course of time. Thank you, sir.
I invite the last speaker of this session, Dr. Mohan.
Good morning, everyone. Today I am going to present this case, an enigma of inexhaustive germs. We had this 3-year-old female child coming from Bankura district of West Bengal who came with the chief complaints of inability to speak for 1.5 months, inability to sit and stand without support for 1.5 months, and there was abnormal movement of all 4 limbs, trunk and neck for 1.5 months. Now, this 3-year-old child was already having global developmental delay. Insidiously, she started losing her previously attained milestones for 1.5 months. She could speak previously, but now she was unable to speak. She could sit and stand without with support previously. She could walk with support previously, but now she was unable to sit and stand without support. And also there was abnormal movements. The movement, now coming to the movement, it was involuntary, side to side, stereotypical movement of neck with jerky, repetitive movement of all 4 limbs in resting state, which aggravated on attempting to do any activity and got diminished when she was supported. And there was also feeding problem. Now coming to the relevant negative history, there was no history of any convulsion, intake of any anti-epileptic or antipsychotic drugs, gradual increase in head size, psychosocial issue, hearing impairment, and no past history of any other illness. All of these ruled out pseudo-regression. Other negative histories were also taken, and other histories, antenatal, birth, postnatal, and immunization history, all were normal. Now coming to the family history, she was born out of non-consanguineous marriage, no history of similar illness in the family. Now coming to the developmental history. Gross motor domain, previously her DQ was 50%. Now it was reduced to 25%. Fine motor domain, previously it was 100% DQ. Now it was 50%. Language domain, previously it was 100%. She could speak full name at 2.5 years of age, but presently it has reduced to 16.7%, and this was the maximum reduction. No significant reduction occurred in the socio-adaptive domain. Coming to the general examination, it was mostly normal except for the reduced GCS and mild pallor. Now coming to the anthropometry, she was stunted, she was underweight, and she also had failure to thrive. The head circumference was measured and it was found to be less than 3rd percentile. MUAC was also low. Now coming to the head to foot examination, the positive findings of microcephaly, hypertrichosis with excessive hair growth, convergent squint in right eye, horizontal nystagmus with fast component towards right side, ataxia, and mild pallor. And these were the other relevant negative findings. Coming to the examination of the CNS, higher mental function was within normal limit except for GCS. In the cranial nerves, Menos reflex was present in all directions, PLPR was present, and bilateral optic atrophy was present in fundoscopy. Coming to the examination of 3rd, 4th, and 6th nerve, convergent squint was present in right eye, and horizontal nystagmus was present with fast component towards right, and same for the vestibular nerve examination. Motor examination of upper limbs was done, which revealed UMN signs, and also for the lower limbs, UMN signs were present. Cerebellar signs were positive for ataxia, intention tremor, past pointing, finger nose taste, and nystagmus. This is a video demonstrating the abnormal movements and also the movement of the neck and all 4 limbs. And in order to stand, she had to be supported. Sensory evaluation was within normal limits. Other systems were also within normal limits. Now coming to the case summary till now, a 3-year-old girl child with global developmental delay came with insidious loss of previously attained milestones and ataxia for 1.5 months. Microcephaly was present on examination along with hypertrichosis, failure to thrive, squint, and bilateral optic atrophy. Human signs were present along with the positive cerebellar signs were there. But there was no history of any seizure, dementia, or cognition problem, and no history of any organomegaly or macrocephaly. So we thought that we were predominantly dealing with a white matter disease. Differential diagnoses were metachromatic leukodystrophy, Krabbe's disease, Pelizaeus-Merzbacher disease, autosomal recessive type, and mitochondrial disease. Now investigations were done. Routine investigations were all normal. ABG revealed high anaerobic metabolic acidosis with lactic acidosis, and USG revealed coarse ecotexture of the liver. VEP was also abnormal, suggestive of defect in anterior visual pathway, indicative of demyelination. Now, neuroimaging was done. T2-weighted MRI showed bilaterally symmetrical hyperintensities in corticospinal tract, in periaqueductal gray matter, and bilaterally symmetrical hyperintensity in the brainstem. Further, EMA spectroscopy was done, which showed significant lactate peak. Then coming to the final diagnosis, clinically we had 4 points. There was presence of global developmental delay with neuroregression, microcephaly, hypertrichosis, failure to thrive, ophthalmological and hepatic involvement, UMN, and cerebellar signs. Biochemically, there was presence of high anaerobic metabolic acidosis with lactate levels, and lactate levels were increased. And radiologically also there was presence of bilaterally symmetrical hyperintensities in corticospinal tract, periaqueductal gray, and brainstem with MRS showing lactate peaks. All of this suggested that it was a case of Leigh disease. Now, genetic analysis was done for the most common mutated genes because of financial constraint and was found to be negative. We are planning for further whole genome sequencing. Management, she was treated conservatively with physiotherapy and vitamin supplements. She improved transiently, but when she was followed up, no significant improvement occurred. Now coming to the discussion portion, Leigh disease, as we all know, it's a subacute necrotizing encephalomyelopathy, and it impairs the function of the mitochondria. It impairs oxidative phosphorylation, and so ATP production doesn't occur, and all the major organs which are involved are summarized here. Now the incidence is very rare, occurs in 1 in 36,000 to 40% live birth. Inheritances, it's mainly nuclear DNA mutation. Autosomal recessive is most common. Extreme recessive can occur, and there can be mitochondrial DNA mutation that comes from the mother, and sporadic occurrences also there. Now the main point which was there, that mitochondrial disease is mainly present with features of gray matter abnormality. But here we are finding that it is predominantly a case of white matter abnormality clinically. So review of literature was done which showed that white matter involvement has recently been recognized as a common feature with multisystem mitochondrial defects in either mitochondrial genome or other genes. And in general, lesions caused by mitochondrial DNA point mutations predominantly affect the deep gray matter with minor peripheral white matter involvement. This is another case report. And to summarize, if there is involvement of nuclear DNA, then there will be predominantly white matter affection. And if there is involvement of the mitochondrial DNA, then there will be predominantly gray matter affection. The survival rate is low. It's 20% at the age of 20 years. And the mortality rate is very much high, as found out in the case reports. It's 68% by the age of 15 years. And these are the various treatment strategies. Here I am ending my presentation. Thank you. HIV, the presentation would not have been so much chronic presentation. It should have been acute presentation.
No, do you go for the normal
Heart, yes, echocardiography. Yes, ma'am, I have already mentioned. Ma'am, echocardiography was done, which was normal. Ophthalmological examination was done. VEP was abnormal, and also there was presence of bilateral optic atrophy along with nystagmus and squint in diagram. Nystagmus occurs in Leigh disease, but it is classically found to occur in Pelizaeus mosquito. No, actually, there were financial constraints. The patient party couldn't support, but do that. But we are planning to do that later. Already, the MRI is proving that it's a mitochondrial disease, and also the patient is not recovering properly. So we can't force the patient party to go for such costly investigations. But if we can manage, we'll definitely do it.
Thank you. Thank you so much, all the participants. That was a nice collection of cases to start with. We will declare the results of this session after the next session. So thank you so much. We will give out the prizes to all the participants now itself, but we will declare the winner and the runner-ups after the next session. So I hereby invite all the participants one by one to accept the prizes from our esteemed panel members. So Dr. Shomukh Paria. Dr. Orko Kormukar. Dr. Athray Shamantu. Dr. Olindro Kapar. Dr. Bondhu Gopal Sharma. Dr. Shomudin Sarkar. And Dr. Madhusri Dutta.
Please wait, don't come out.
Thank you everyone for this wonderful session. Now I would like to invite Professor Fatma on stage for the felicitation of our respected judges.
Bhagat Singh once said, "The sword of revolution is sharpened on the webbing stone of ideals." As the country immerses itself in the celebration of the 75th anniversary of independence, a group of doctors immerse themselves in this flow of ideas here at the annual office practice CME conducted by the Institute of Child Health, Kolkata. Good morning to all the delegates and faculty. I welcome you all to this gala event. After a hiatus of 2 years, this event has been a very well sort of event, and we have a lot of participants of it today. I thank all the judges and the participants for the previous session, and let us now carry on this flow of ideas to the dermatology session. And I would now like to call upon Dr. Shomukh Kaur to chair this next session and introduce the speakers. Dr. Raghuveer Banerjee, Dr. Rajiv Kumar, and Dr. Abhijit Shah will be the presenters today.
Thank you, Dr. Ji. And good morning, esteemed colleagues, friends, and beloved PGTs residents, and welcome to this session today. Happy Independence Day to all. With me, I have two, my good colleagues today, Dr. Rajiv Malaka and Dr. Abhijit Shah. Unfortunately, Dr. Raghuveer Banerjee could not make it because of family exigencies related to health. So, Dr. Rajiv will start the ball rolling. Let me tell you very clearly that our timing is 45 minutes, and we will have over the gas at 10 o'clock. So we will come down of the gas at 10:45 because our sponsors, several members of the sponsors at different angles looking at us. So they will take a call if we finish it early. we have no issue. Yes, over to you, Rajiv. We have a set of interesting cases in pediatric dermatology. I'm sure that all of you will enjoy, and it will be very analytical, emphatic, to the point, brief, and for your purpose. It is basically a set of cases of, as you can see, the title, pediatrician's perspective. So over to you, Rajiv.
Thank you, Shantapanta, for that great introduction. We are going to start our interesting case series, and we have decided to give you value for your time, and we will restrict our discussion to the relevant cutaneous and mucocutaneous findings which point towards the relevant diagnosis, and we will welcome your queries so that we can answer specific problems that you face in your practice. This is a 3-day-old child. When we went to see her in ICU, we found her presenting with such black patches circumferentially involving the right limb, lower part, and similar black patch on the buttock. This is surrounded by an area of redness. This is what the cutaneous finding looks like. Now, let's take a closer look. Here, I believe you can appreciate the margin. If you look at the margin, there is a angular, irregular appearance in the margin, which is unfortunately not very clear because of the lower resolution of the photograph. But I have tried to make it obvious by making a line here in orange. And on the other side, in the center, I've tried to augment the appreciation of a 2-dimensional photograph by trying to make it 3-dimensional. You can appreciate a sort of a depressed area, which is black and made up of primarily crust with a little bit of hemorrhage. So these two are the findings which suggest the diagnosis that we had. Number one, while we're trying to explain, how can we explain this irregular finding? Basically, we know that the skin of the surface of the skin is supplied by the dermal blood vessels, and they have a hexagonal distribution of each individual capillaries. So each individual capillaries tend to supply a roughly hexagonal area of the skin. So if we have disruption of the blood supply, and there is effect of or hypoxic damage of the skin, the edge or the margin, if you look at it, will have an irregular margin exactly like the edge of a bee hive, where it is made up of multiple hexagons. And the center area there is a very typical finding which suggests cutaneous necrosis, and which will settle down to form an eschar. So from these findings, this strongly suggested to be, from the cutaneous findings, a case of neonatal purpura fulminans. Unfortunately, it is hidden under the screen sharing note. Shantapanta, would you like to take on? This is all for this case.
Okay, no, but I remember some graphical presentation of this.
No, that's it.
Okay, fine. Right. Here you can see something which is very interesting. It is not only applicable, but why such inclusive occurs in particular purposes. I'm sure that all of you know. Basically, because of hyperphosphatemia rate, there is deficiency of protein C or protein S, either acquired or congenital deficiency. Protein C and protein S are glycoproteins, vitamin K dependent. So as a result, when they are deficient, there is hyperphosphatemia state in the capillary sector. And this is the concept of triangular, area of skin being supplied by a single capillary at the center. Right? So the moment this capillary is blocked because of hyperphosphatemia, that entire triangular area gets blocked off. So if you now add one triangle another, so the entire border will come in a connected fashion. That's why this is not only applicable for particular fulminants. Any state where there is hypercoagulable situation in the system, and as a result, the skin is also affected. You will see always a connected margin of necrosis of the skin. That is exactly what Rajiv was trying to say. And as you all know, purpura fulminans is a very toxic condition. The child is very toxic. It needs very aggressive treatment. And the reason, as I told you, most common is a meningococcal infection. However, it can be seen in a lot of other infections like post-varicella, post-scarlet fever, post-typhoid, even in rickettsial. And now, Abhijit would like to say something about the treatment of it.
Thank you, sir. Yes, it's a life-threatening condition, medical condition. We cannot wait, we cannot relax. You have to be very, very aggressive with this condition. And as sir already said, most common causes are infections, different type of infections. So without wasting any time, starting regular antibiotics, and before that, send the blood or for culture and sensitivity once it comes. Start the exact antibiotic. This is one part. And number two, you have to treat the patient in ICU. We have to take care of all the electrolyte, temperature, hydration status. And as it is a cutaneous marker, say that way. So it is a cutaneous marker of disseminated intravascular coagulation. So that part should be taken care of properly. And from that point of view, fresh fluid plasma is an extremely important part of the treatment that should be infused. In some centers, they use heparin, some centers do, but this fresh fluid plasma generally has at least this is the mainstay of treatment. Otherwise, what happens? Otherwise, if you delay, you lose the patient. Your mortality rate is quite high, or you will end up morbidity, which is not acceptable, like your amputation, like your gangrene. So these are the treatment part. Thank you.
If anybody has any questions, otherwise we'll switch over to the business. So as there is no question, next is.
This is something that you should know, because I believe that you are and will be encountering such cases in near future, especially in this region of India. And there will be numerous different types of presentation because we are going through an epidemic of this condition. It is very difficult to distinguish, but you should always keep in mind about this condition whenever you encounter a dermatological problem. Here there is not much to see. You can see a few patches which are roundabout reddish and blackish, and it seemed to be a little bit of concentric in appearance. There is some degree of scaling which you can appreciate from the tangential lights here, and a few bumps can be observed. To make a diagnosis, we need a proper context. The next photograph will give you the proper context. Here, this is the mother of the child, where we can see a typical lesion. Not exactly typical, but still, for now, it is typical as compared to whatever we are finding in the child's back. Here we have erythematous scaly plaque with a sort of an annular appearance. And if we now look at this lesion, you will find there are multiple concentric circles. This is a very typical appearance for these sort of cases, which is known as the pseudo-imbricata appearance, where what happens normally, the patient is applying topical steroids, which tend to significantly reduce the inflammation or the disease activity for a time being. But the disease continues to increase, or the hyphae continues to progress in absence of obvious inflammation. And when the effect of the steroid is no longer there, it again manifests as an inflamed skin area. Again, the patient applies something, the inflammation subsides, but the hyphae continues to progress. And then again, after the effect of the anti-inflammatory medication subsides, you have an inflammatory lesion. This gives the typical pseudo-imbricata appearance, which is classically seen in tinea incognito, which is, I believe, you will be seeing in your practice quite regularly, and you have been seeing for now. Shondipanda, would you like to continue?
You know, this appearance of single indicator, you must have read tinea indicator. That is some species of dermatophytes like metabophytes and Typhimurium. They produce concentrated. And earlier we used to see it, but not very often. It used to be a rare observation. But what has been happening over the last 10 years, you must know, all of you must know, that there is a dermatophyte epidemic going on in India. And I must say, over the last 10 years, more than 100 publications on dermatophytic epidemics in global journals, starting from Lancet, New England Journal of Medicine, and all top dermatology journals have been written by the Indian workers. There is a group of Indian workers who are working in dermatophytic infections, all our colleagues. This is because one of the reasons is rampant use of topical corticosteroids for fungal infections. This is not to be done. Never use any topical antifungal steroid combination or 3 combinations of steroid antibiotic fungal. Right? Rather, if you are not very sure about the fungal infections or dermatophytic infections, better use a moisturizer. But don't do anything, just observe. But don't use a steroid. Then you are actually causing more harm to the child. And that's why this will be implicated. Something which we have never seen earlier, the dermatophytic infection, once we diagnose in a child, we see that multiple members in the family are affected. Just like scabies, which we have not seen 15 years ago. Now it is almost true for more than 95% of the cases. They have multiple members in the family having very severe dermatophytic infections. Dermatophytic infections, it is so confusing, presenting just like many of the dermatologist colleagues, renowned colleagues, they diagnose as psoriasis, somebody diagnosed as eczema. That means it is coming in disguise. So that's why it is called tinea incognito. So all these things have happened because of several reasons. Obviously, there is some fungal strain has changed over a period of time. From typhimurium to metabophytes and other things. And second thing, most important, is the rampant use of topical corticosteroid, that too potent topical corticosteroid. That is not true. So as you can see here, the mother and the child are affected. So this is a very infectious or contagious condition. Skin to skin contact transmit from one person. So,
there's one thing I'd like to say. In our undergraduate years, for dermatology student, we used to know that syphilis is said to be the great mimicker. But nowadays, we can safely say, for dermatological purposes or in the dermatological context, the dermatophyte infection is going to be the great mimicker.
Yeah, I just want to clarify further. If you look at these two lesions or mother's milk and child's milk, what does mean by steroid modified or tinea incognito? That means tinea usually occurs in the ring shaped lesion, central clearing and peripheral spreading. This is the normal appearance. That is to some extent preserved in mother's lesions. So here we can say it as steroid modified. Steroid has been applied both of the conditions, but still this mother's patch lesion is still recognizable. That's why you can call it steroid modified. But please move to the previous picture. But if you see the child's back, unless and until you are very much trained, you have very much trained eyes, it's impossible to identify it as a tinea infection. So it is not at all recognizable. That's why it's tinea incognito. This is one point. And number two, regarding the treatment, if it is a very small lesion, you still can start any plain and simple topical antifungal. There are a lot of topical antifungals available in the market.
Most of them are not active below 12 years of age, but still we use off-label that is extremely safe and tolerable. So you can use any topical and fungal, protein, unicorn, certain anything. You just start that with experienced dermatologist. And for the larger lesions, we oral antifungal. Here, actually, two antifungal can be given. One is fluconazole and one is ibuprofen. Fluconazole also works very good, but still we do not prefer to use fluconazole rampantly because fluconazole is an important drug for invasive fungal infections like meningitis, fungal meningitis, and all that. It works well, but we do not want to lose the efficacy. This is number one. So, but there are a lot of pros and cons in different parts in mind physicians regarding the use of your fluconazole. Just take my words, we in our department using ibuprofen like anything for last 6 months or more. We are conducting actually a study on recent frames of fungal infection, how the is working. Fungal PCR we are doing to find on the strain, and we are using ibuprofen. It is extremely safe, tolerable if you use it with proper monitoring and proper follow. So there is no matter of fear, no matter of scaring things about proposal. Use the proposal, it's not that much harmful as we thought. That's all.
Thank you, Vijay. Over to you, Rajiv. We have to be a bit fast. Okay? We have to more cases and half an hour. Duration of ibuprofen usually 3 weeks. By and large. Local application, Dr. OPE has already mentioned. You can give topical metronidazole 2%, chlorpyrifos 1%, butyl 1%, cyclopyrrolazole 1%, ketoconazole 2%, and there are so many molecules. Now, when your market is flooded with topical antibiotics, there are 35 brands of topical. All are good, it all depends on your personal choice. It cannot be said by any pharmacokinetic study, it has not been carried out. Compare activate one molecule with that. Over to you, Rajiv.
Thank you, boss. On the third case, here we have a 7-day-old child with this classical erythematous geographic shaped plaques, which are evanescent. And this is a classical case of, though a rare presentation of a comparatively common disorder in this age group, neonatal urticaria. Identifying it, and in spite of being such a severe outlook, as such a severe look, the disease is not severe unless we rule out certain syndromes. This can simply be controlled by antihistamines. There are a lot to be said about use of antihistamine in this age group. Shantipanda, please take.
There is no pharmacokinetic study to prove the efficacy of the safety of antihistamines in pediatric, particularly small infants. So it is purely empirical on the basis of personal experience and expertise. So over the last 3 decades, millions of patients all over the world have been treated by thousands of dermatologists in pediatric age group with urticaria, with different types of whether it is chlorphenidone, whether it is hydroxyzine, whether it is cetirizine and levocetirizine. There is no report of any toxicity. So don't be scared. For acute urticaria, we give maximum for 10 to 14 days. For chronic urticaria, we prefer third generation antihistamines, basically non-sedating one daytime and sedating one at night time. Even up to 6 months, don't be afraid. Only thing repeatedly is do the monitoring of the child, clinical monitoring as well as objectives. What is very important here, I would like to say, share with you all, for your purpose, it is very important that whenever a neonate develops urticaria, you have to think much beyond the skin, much beyond the urticaria, because neonatal onset multisystem inflammatory disease or NOID is a condition which often presents with urticaria. And NOID's important clinical manifestation is urticaria, which can be seen even up to 40% of the cases. Along with that, joint involvement like arthritis, and most importantly, CNS involvement. 95% of babies with moment. I have seen one case of moment in our institute. They present with macrocephaly 95%, enlarged frontalis, the sensory neural deafness, and many other neurological complications. So it is very important to identify such cases from the very beginning so that they can be properly monitored, treated. Parents should be counseled, and the prognosis of the condition can be explained to the mother and the father. So I think this is all about it.
This is also a very typical case that you will encounter. But here, the most important thing is to differentiate it from a very common condition. Here you can appreciate there are multiple erosion, areas of erosion and ulcerations. So in the first look, at first it might look like candidiasis, but there are certain points against it. Number one, look, these discrete lesions are discrete and not surrounding a mass area as a satellite lesion. There are no satellite distribution. Number two, they are primarily localized in the convex areas. You can also observe that the flexural areas are relatively spare. This very strongly suggests a very severe form of irritant dermatitis. This is known as the Jacquet's dermatitis or a very severe form of diaper rash. Now we have a next slide, which a little bit of theory, but tells you the basics of how to treat any case of diaper rash by giving you a simple A, B, C, D, E. Shonipanda, would you like to elucidate?
Basically, diaper dermatitis is nothing but chemical. It is because of alkalinity of the stool of the baby mixed with urine that causes the diaper dermatitis when the diaper is kept for a long period of time. So earlier concept was the mother has to change the diaper of the baby repeatedly at least 12 times a day. However, nowadays, as we know, that most of the mothers are working. It is not possible after working throughout the day. At night, mother is expected to change the diaper 4 times at time. So that's why developments and newer technologies and diaper has come to a great extent. There are super absorbent diapers which are now available in the market, which can hold up to 30 kg of urine and stool. You cannot imagine. And there are diapers now available in the Western countries. If you Google, you can see, which are going to come in Indian market, where this is called super technology diaper or electronic diaper, where when the diaper gets a little bit soaked in the mobile of the mother, yellow line dot comes and beep sound comes. When the green sign comes, when it is more soaked, then a yellow light comes. And finally, when the diaper needs to be changed, beep sound and the red light comes. So these are called super electronic diapers, which are going to be available in Indian market soon. Ovi, you would like to say anything about it? Okay, fine. So cleaning, as it is mentioned very nicely, ABCDE by Raji, that is very important. Next case.
This is an interesting case. When we first saw the patient, it's a teenage girl, very early teen, with a very few erythematous, slightly scaly, a few pustules are there, a very few lesions. There is a significant amount of thick scaling in the scalp. And this is a look on the thigh, where you can also appreciate the bright red erythema with a sort of a ring-like distribution of these pus-filled pustules. After 7 days, the presentation looks like this. This is the back, where you see the extensive amount of pustules are formed, and they have sort of coalesced to form legs with an area of central clearing. There is areas of scale peeling, Same thing on the neck. And this is the back where you can see the lakes of pus formed here. There are erythema, central area, skin peeling. There are pus-full areas. And this is the thigh. And this is the arm. So almost the whole body is involved and the lesion has progressed. Now, without going for any further systemic manifestations, let us look at the histopathology. We have done the biopsy here. Then we'll talk about the disease and how to think about it clinically. In the histopathology, here you can see there is significant amount of exocytosis. That means infiltration. There is significant amount of parakeratosis here. And these are nests of neutrophils, which you can see in the upper surface of the stratum malpighi. So this is a classical case of pustular psoriasis. Now, there are several types of pustular psoriasis. The pattern that you saw is classically represents the annular variety. You have to rule out about the type of pustular psoriasis, the type of pustular presentation. The pustular presentation can be because of the von Zumbusch type, can be because of a drug-induced eruption, which is known as acute generalized exanthematous pustulosis. It can be because of localized irritation. It can be because of an annular character, which we can solve. Shondipanda, would you like to take up?
Yes, basically, if you are listening carefully, and if you have known it, you cannot miss the diagnosis of pustular psoriasis. I mean, this type of generalized pustules does not occur in any other conditions. So this is not an extensive hepatitis. It doesn't happen like in an immunocompetent person. They have anti-child immunocompromised. Then you have probably thought of it. And second thing, that usually with this degree of infection, suppose you are thinking of an infection, bacteria. The child will be toxic, very high fever, high temperature. This type of pustular psoriasis, they are more or less very indolent and innocuous. There is no fever, no toxicities. So that is how you think. And next, your thinking process should be, you should ask the question whether the child has been prescribed a potent steroid to apply all over the body, or oral steroid has been given, thinking of something else. That is the inciting factor or precipitating factor from just few class of psoriasis to generalized pustular psoriasis. That needs to be properly addressed. Regarding the treatment, how is it?
Thank you, sir. Actually, I just want to mention two things. Number one is it's a very typical presentation. These pustules comes in crops. Once one crop goes, then further next crop comes. This happens. And two important differences, like I already mentioned, acute generalized exanthematous pustulosis that should be excluded. And another nowadays, like also mentioned in this initial talk regarding the great limited character of pinia infection. Nowadays, topical steroid, if you apply topical steroid all over the body, sometimes pinia will be this kind of thing. So these two things should be excluded. Regarding treatment, the drug is cyclosporine. Start with maximum dose. Don't hesitate to start with maximum dose. Otherwise, if it's a fatal condition, if it's a serious condition, not fatal, but serious condition, start cyclosporine maximum dose. It will tide over the situation very quickly. Then, once the skin is almost pustule free, start decreasing the cyclosporine very slowly and gradually. Do not stop abruptly, otherwise you will invite recurrence. And there are a few other drugs which are also very good, which can be used where cyclosporine cannot be used because it's a costly molecule. You can use methotrexate, as I have always referred to as a poor man's cyclosporine. Asymptotic, another good drug. That means anyhow you have to treat the patient aggressively with oral medication. Three drugs are very important: cyclosporine, asymptotic, and methotrexate. Thank you.
Thank you, Abhijit. Now over to you.
And this is a very interesting case. There's a comparison between two different cases, which may look similar, but have different etiologies. Here, both of the patients have a sort of a subacute eczematous dermatitis on the back, but the distribution pattern is a bit different. Here you can see the distribution pattern involving the outer aspect of the gluteal region, and here it is localized to the posterior part of the thigh. So if you compare, if you think about certain commonly used things in our daily life, you will find that the shape of this correlates with the appearance of this, and the shape of this correlates with the appearance of these. So this is a classical case of toilet seat dermatitis, and this is a classical case of posterior thigh dermatitis. You can have both of these conditions in a case of an atopic dermatitis child, or simply it can present isolated without the presence of an active atopic dermatitis. But depending upon these shapes, you can easily identify the inciting or the triggering agent, and thereby advising properly. Otherwise, using any type of medication until and unless the triggering factors has been identified and avoided, significant improvement will not be achieved. Shandibanda?
This is not very common all over the world. In fact, Google, you just Google toilet seat dermatitis or posterior thigh. You will see it is very common all over the world. And because of the change of style of lifestyle pattern, and basically they are contact because of the toilet seat material, porcelain material. And second, the other one is because of child sitting on a table in the school or at home on either leather cover or wooden with a polish, antioxidant and other things. They cause contact chronic contact. So it needs to be treated just like an atopic dermatitis with moisturizer, steroids, and antibiotics. Pardon?
Yes, that is advisable.
I think yes, that is one important thing. Very rightly say that people are coming back to Indian style in many ways nowadays. So this is one thing definitely. And second thing is the giving the cover to the child. This we always say small girl rather than those who develop posterior thigh dermatitis. We tell the parents, the mother, use a blue one type of undergarment rather than the smaller one. That nowadays the small children they wear small one. So the nutshell is that it's basically this posterior thigh dermatitis is usually occurred due to the posterior thigh coming in contact with the metal part of this stool benches. So it's actually allergic dermatitis, and this toilet seat dermatitis would be either allergic or irritated. Irritated in the sense if we wash the toilet seat with the harsh detergent that is not properly clean, these red marks may cause irritation. And allergic in the sense, as I said, it comes with a wooden varnish and polish, all these things. So main treatment is to avoid it. You have to avoid those things which are triggering this stress. Along with that, just treat the patient like here. I just probably is the right platform, and here I just want to mention I would like to let all you know about a very pertinent society that is called Society for Retinal Studies. In short, SES. This is the actually Green Society of Dr. Sandeep Bhatt, and it has recently been launched all over the India in many cities, and it got huge response from every corner of our so it's a society which has been formed by Sir and many other colleagues just to promote pure and simple academics and research on it. So if any of you would like to know more about it, we'll give you the link and details and website address. You can join with us and we can mention new projects and new academic discussions of it.
Thank you. The next few cases will be presented by Dr. Rajit Shah. Over to you.
Thank you, Rajibda. Now we are going to case 7. Am I audible? This is the child. You can see there are lot of number of blisters over there. Few are large, few are small. And if you look carefully at this red marked areas, you can see some arterial plaques over there, out of which these blisters are developing. And there is a large blister in the center, and multiple small blisters are developing surrounding the these large blisters. Though the appearance is not fully formed, but this kind of presentation is called string of pearl appearance. So it's actually autoimmune bullous disorder, very commonly seen in childhood. And further confirmation, you can do a histopathology. I'm sorry, this is a bit blurred, but at least you can appreciate this subepidermal bulla. This is epidermis. This is epidermis. Below the epidermis, in the upper dermis, there is a bulla. Inside, there are some fibriness that, and here, if you look carefully, you will get multiple neutrophils. So it's a subepidermal bullous autoimmune disease. And for further confirmation of etiology, level of split, where the splits is occurring, at which level, you need to do some immunofluorescence testing, direct immunofluorescence. Over to Sandeepan sir. Rajibda will want. Yes.
Please go to the first slide.
Yeah.
This is an interesting thing that I like. You can observe that there are small blisters forming in a red B. This is known as the mosaic appearance. This can be confusing. We recently had a case in ICH where the patient presented with these sort of mosaic appearance, initially expensive, and it was initially diagnosed with this so such cases which may present initially as case of erythema multiforme, follow them up properly. Some of them may involve disease. So you need to keep it in mind.
Absolutely. The treatment of this condition is not very difficult, because by and large, by 5 years it develops, and by 12 years the completely resolve in more than 80% of the cases. If you do the histopathology, you have seen subepidermal. You know, if you do the immunofluorescence, it shows the position of IgA. So that's why it is called IgA disease in children. And it responds very nicely to capsule. Some cases do not respond to capsule, where you have to give oral corticosteroids. Even in some cases, it does not even respond to corticosteroids, because it needs to be treated on a long-term basis for months to years. Their cyclosporin has been found to release. Right now, we are treating one child with cyclosporin, and she is showing good response. Next case.
Yeah. Just first see this. If you see the cheek of the face, probably many of you can diagnose the condition. But whenever you will look at the arms and legs, maybe you become a bit confused. So it's nothing but, yes, some of you are thinking in your mind, yes, it is, you are right, it is pityriasis versicolor, but in an extensive form. Pityriasis versicolor, sir, please continue. What is and tell something about it. What is it? How to treat?
No, basically, there is one sign. If you just scratch over the versicolor, you see at the end of the scratch, the scale is still appearing. And this is there in our textbook of dermatology. This is called fingernail sign. So it is basically scaling, and because it is caused by villus previous scale. So now Rajiv will describe the bootstrap observation, because he only took the photograph of the
Yes, I'm just showing the Woodflam examination finding, because if you are confused, then sometimes you need to take the help of Woodflam. So this is the Woodflam's finding. Rajendra, please elaborate.
Here you can see sort of a dirty yellowish and which cannot be appreciated properly. But it is unfortunately because the camera sensors that we have do not respond very well to other highlights. But you can at least appreciate a little bit of yellowish discoloration or fluorescence from the patches. The disease here is extremely common, but the extensive nature is a little bit atypical, which might confuse you with certain other common conditions coming up nowadays like hyperhidrosis. So in order to differentiate them, the ultraviolet light exposure and subsequent fluorescence might be helpful in teaching the diagnosis.
Next case.
Yes, next.
So many of you can diagnose it. I'm sure you are quite good at dermatology. So it's a verrucous large nodule over the around the anus, and also you can appreciate if you look carefully there are multiple small papules are developing. So this is nothing but verruca vulgaris at the genital area. But what is its importance? What is the significance? See, definitely, if you look at the other sides of the child or the caregiver, the mother, you can find verruca over the fingers and these things. So it might be a case of autoinoculation. That is a possibility. But what is most important, you must have to rule out the cause of child abuse, because under POSCO Act 2012, it's a punishable offense. Yes, it is a sensitive issue. Lot of handholding is required. You need to take the parents in your confidence. Sometimes you may need some counselor, but that thing should be ruled out or established for the future, for the sake of the future of the baby. Otherwise, the baby's future will be devastated. Over to Sandeepan sir. Over to Sandeepan sir.
I think very treatment also might have said, either telepathy or electrical radiation or cryotherapy is the treatment of choice. Only thing you have to follow this child, then you need some mechanisms. And the potassium hydroxide, you have to teach the mother that the mother herself can apply how to apply potassium hydroxide. It is not a big deal. Very simple, just a toothpick touching can be done. So that advice is very important. Regarding the other things, we has already had.
Rajitha want to say something? Next case.
We have got limited time, just 7 minutes.
So it's a quite interesting case. At first glance, you might mistake it as vitiligo, but actually it is not. Over to Sandeepan sir for further elaboration.
No, no, that is wrong. Sorry, we came on that class. I told it I knew that this will happen because the previous session went on for a longer period of time. So that's not our fault. Because our sponsor is otherwise not sponsored. We try to finish it. So this is very, very classical of a condition where you see a depigmented, well-demarcated patch without any convexity of the borders. Convexity of the borders suggests vitiligo, and its location is median or paramedian. It may or may not have associated white foreground. So the diagnosis is very straight and simple, bipolardism, right? Only thing whenever you diagnose bipolardism, you have to rule out associated systemic, particularly musculoskeletal, ocular, and neurological associations. So these children need, long-term follow-up for at least 10 years, if not more. Here, another important thing I'm sure that you have observed is that, erythema or salmon patch. So at least you can tell the mother that, look, this red patch is going to disappear maximum by 6 months to 1 year. But the white patch won't disappear, it will remain. But don't worry, other patches won't develop like vitiligo or other parts of the body. Only thing, it will increase in size proportionate to the growth of the child. So that is very important. And at a later date, plastic surgical removal, lot of reconstruction, and other things can be done.
Two things I'd like to say here. Number one, a very important differential here is depigmentosis. To differentiate between these two conditions, number one, look at the age. You will have a much more irregular and angular brushstroke-like age in case of venous depigmentosis. Here we do not have that. Number two, the degree of depigmentation here is almost complete, which is generally not complete in the case of venous depigmentosis. And number three, about the treatment, we now have a very simple treatment which we can do. We do melanocyte transplant, bone culture melanocyte transplant, which is very effective in reducing these sort of pigmentation after the patient has attained vision.
Okay. Yeah. So This is a classical case. Sir, please elaborate it regarding his presentation. My baby is crying.
Basically, this is very common cases. I'm sure that all of you see it in practice. A very irritable baby presenting with a history of chronic diarrhea and perioral lesions, acral lesions, all are eczematous lesions. And the first slide is you must have seen the child maybe has kept the eyes closed. So whenever you try to take a photograph, then immediately closes the eye. That is because of photophobia. So photophobia, chronic diarrhea, eczematous lesions, facial areas and acral areas makes the diagnosis of acral monocytic enteropathica. There are three types, but the most difficult type is something where there is a genetic mutation of ACL37A4 gene mutation. Otherwise, gene supplementation is the treatment of choice, and if it is acquired, then the response and prognosis is very good. Otherwise, genetically mutated cases, lifelong supplementation of gene is to be done. Next case, we are going to finish in 2 minutes.
So this is the last case. Translucent large papule along with multiple small satellite lesion. How to treat, sir? And this is a case of molluscum, as you can see.
Okay. So basically, see, this is a very sensitive area around the eyes, but don't worry, we are very expert in treating such conditions. You can advise the parents to use 5% potassium hydroxide and show the mother how to apply potassium hydroxide. The advantage of potassium hydroxide is that it is very effective and it does not burn or causes burning sensation in the babies. Just like trichloracetic acid, it doesn't burn. Trichloracetic acid causes a lot of burning. So even if the baby rubs, I could see some gestures from some of our colleagues that showing these type of things. Even if the baby rubs, nothing happens. This is number one. Number two, the bigger lesion will take longer period of time. One thing you should not do with a single molluscum contamination lesion, I have seen many of our pediatrician colleagues say, "Oh, nothing is to be done." Don't do that, because one single lesion of molluscum contamination is going to multiply. It is very contagious. If the baby rubs the eyes and scratches another area, this is going to spread by autoimmune population. And in one molluscum contamination lesions, there are hundreds of viruses. So this needs to be treated. If needed, under local anesthesia, or for that matter, even for those children who are very fearful child or very resentful child, restless child, you might have to do vitamin anesthesia, take the help of your anesthesiologist friend, and remove all the molluscum with that.
So that's all. Next, we have this slide. As I have already mentioned, Society of Eczema Studies, dream project of Dr. Sandeep Andhar. So we'll do a lot of works in future, and if you're really interested, you can log into the website and join with us for further academic endeavors. Thank you. Thank you very much for your patience hearing. You are a wonderful audience. Thank you, sir.
Thank you, Vijay. Thank you, Rajiv. Thanks to you all for your presence and interaction. And last but not the least, thanks to our sponsor, University of Healthcare, for not only sponsoring this particular event, but always being very kind in sponsoring all academic endeavors of Department of Pediatric Dermatology of our Institute of Child. Thank you very much.
Thank you so much, sir. As usual, it was a very interesting session. For me, it's the most awaited session right now, and it's my great pleasure to call upon Professor Priyanka Pal, who will be introducing Professor Surjit Singh.
So a very good morning. For this August gathering over here, I don't think Professor Surjit Singh really requires an introduction. Just to say a few words that he is the professor and HOD of Pediatrics, PGI Chandigarh, but more importantly, he remains the guru and mentor of the numerous pediatric rheumatologists throughout the country, the budding pediatric rheumatologists, and definitely he is the instrument behind spreading of dissemination of knowledge of pediatric rheumatology and of course, Kawasaki disease throughout the country. So before Professor Singh takes the dais, I would request everyone in the hall to stand up for the national anthem. Thank you.
Okay, thank you, Dr. Priyankar. So I shall be sharing some of our experience about Kawasaki disease based on 6 cases that we have managed over the last few years. These cases go on to show not how much we know about this disease, but what is our level of ignorance about this disease. A disease that was first reported in 1967, and even in 2022, we understand so little about this condition. Kawasaki disease is a very common childhood febrile disorder, unfortunately not being picked up as frequently as it should be. And even today, the overwhelming majority of children with Kawasaki disease remain undiagnosed in our country. So this is a medium vessel vasculitis with a special predilection for coronary arteries, but not only the coronary arteries. It usually affects children below 5 years. The most common age group is 0 to 2 years. And when it affects children below the age of 6 months, it can be a diagnostic nightmare. In fact, there are few conditions in pediatrics that are more challenging to diagnose and manage than a small baby with Kawasaki disease, especially if he happens to be in the age group 0 to 6 months. To make it more complicated, Kawasaki disease can affect adolescents, can affect adults, and we've had patients in their 20s having Kawasaki disease and with disastrous consequences sometimes. The diagnosis of this condition depends on the recognition of a constellation of clinical findings that keep on changing from day to day. And that is how this condition becomes so challenging to diagnose. Even today, there is no reliable laboratory biomarker for the disease. Several biomarkers have been tried, several genetic markers have been tried, but the diagnosis of this condition as of today depends on the clinical recognition of the constellation. This disease was first described by Dr. Tomisaku Kawasaki, a pediatrician who worked at Tokyo, at the Tokyo Red Cross Hospital. He published his first series of 50 patients in 1967 in a Japanese language journal called Aerology. It did not attract much attention till he published in 1974 in the English language in the journal Pediatrics. And since that time, this disease has been attracting worldwide attention. This disease, for some reason, is more common in children of Asian descent. And the 4 countries that have the world's highest incidence of Kawasaki disease all happen to be in Asia. Japan, Korea, Taiwan, and Singapore are the only 4 countries in the world that have incidence figures above 50 per 100,000 children below the age of 5. Why this disease preferentially affects children of Asian ancestry, we really don't know. But the fact remains that for some reason, this disease is more common in the Asian ancestry. If we look at the global epidemiology, we have countries like Japan, Korea, Taiwan, and Singapore that have incidence figures in the range of 50 to now 300 per 100,000 children below 5. And in these countries, what is worrying is that the incidence continues to rise. That means the incidence has not plateaued in this category 1 group of countries. Not only is the incidence very high, but the incidence continues to rise. In category 2, we have most of the developed world, Europe, North America, Australia, New Zealand. Here, the incidence rates are much, much lower, 15 to 30 per 100,000 children below 5, and the incidence has plateaued. In category 3, we have the 2 most populous countries in the world, China and India, from which, for understandable reasons, we do not have reliable nationwide data. We only have city-specific data, and in China, the rates are very variable depending on which city you come from. For instance, in Hong Kong, the incidence is 74. In Shanghai, it is 43.1. While in Western China, especially in the hilly areas, the incidence is much lower. From India, we have data from our own institute in Chandigarh, and our incidence at present is around 8.9 per 100,000 children below 5, which is somewhat near the European figure. Kawasaki disease is not a one-time benign disease of childhood. it can leave behind several devastating coronary sequelae, as shown in these children who've had coronary artery aneurysms. We know that if Kawasaki disease is not diagnosed, 15 to 25% of patients can develop coronary artery abnormalities. That means almost 1/4 of children who develop Kawasaki disease, who are not diagnosed, who are not treated, will be left with coronary sequelae. But what is not frequently recognized is that 3 to 5% children who do receive appropriate treatment will also have this sequelae. Now, 3 to 5% does not appear to be a very large number, but considering how common this condition is, this figure becomes worrying, that in spite of prompt diagnosis, in spite of appropriate treatment, these children will still develop sequelae. Now, in Japan, 1% of all children born in Japan will develop Kawasaki disease before the age of 10. 1%. 14,000 children in Japan develop Kawasaki disease every year. So this 3 to 5% figure becomes important. In a country like India, one can imagine the total number of children with KD all across our country. So we really need to be very worried about Kawasaki disease. So I'll give examples of 6 patients where we had a lot of difficulty in diagnosing and in treating these patients. And this just goes on to show how difficult this disease is to understand. So this was a 5-year-old boy who presented with fever for 17 days. He had been diagnosed to have enteric fever, had received treatment for enteric fever, but the fever would not go off. So he was referred to PGI with persistent fever. He was irritable, but had no other symptoms and signs. So when he was received in the emergency room, the treating team worked up for enteric fever, ruled out other causes of fever, started treatment for enteric fever with ceftriaxone, but the fever persisted. So they thought, why not rule out infective endocarditis? So they did an echo, and on echo they found giant coronary artery aneurysms. So this was fever as the sole clinical presentation of Kawasaki disease. It's quite possible that this child had had some features of KD that were missed initially, but when we saw the patient, he was just having fever and nothing else. So fever as the sole presentation of Kawasaki disease as a manifestation of what is called incomplete Kawasaki disease. So that is how tricky this disease can be. This child went on to develop giant coronary artery aneurysms, and 5 years down the line, he still is on anticoagulants. Case number 2, this child presented with fever for almost 3 weeks. He was irritable. He had skin and mucosal bleeds. He was in hypotensive shock. So he was immediately transferred to the intensive care unit, treated for septic shock, but there was very little improvement. It was at this time that the treating doctors in the ICU noticed some features of Kawasaki disease in the form of desquamation over the fingertips, in the form of a red tongue, some conjunctival changes, and this child was ultimately diagnosed to have Kawasaki disease shock syndrome. And this child happens to be the most severe case of Kawasaki disease that we have ever managed at our institute. He required as many as 3 doses of intravenous immunoglobulin. He required infliximab. He required methylprednisolone, oral cyclosporin, but he came out. So this is the presentation of Kawasaki disease, which is known as Kawasaki disease shock syndrome. An increasing number of these patients are being identified in intensive care units throughout the world. And Kawasaki disease shock syndrome can sometimes also be accompanied by macrophage activation syndrome, as was the case in this patient. And it becomes even more difficult to diagnose these patients because these patients can have very prominent thrombocytopenia. So this is how complex Kawasaki disease can be. And Kawasaki disease shock syndrome and Kawasaki disease macrophage activation syndrome are perhaps one end of the spectrum of the cytokine storm syndrome that we see in Kawasaki disease. So this is a brief publication from our center on children with Kawasaki disease who had macrophage activation syndrome at presentation. And when you have such a combination, quite understandably, the diagnosis can be very challenging. We now know that macrophage activation syndrome can occur in up to 1 to 2% children of Kawasaki disease. It was known earlier that children with Kawasaki disease who had thrombocytopenia at presentation tended to have a more severe form of Kawasaki disease. But what was not known at that time, that this thrombocytopenia is because of the macrophage activation syndrome that can occur in patients with Kawasaki disease. So as a corollary, whenever you have a child with severe Kawasaki disease who does not seem to be responding to the usual treatment with intravenous immunoglobulin, rule out macrophage activation syndrome. And we are often surprised how common this happens to be the case when you are dealing with these patients. This was a 6-month-old boy. And as I said earlier, whenever you see Kawasaki disease in young infants, the most troublesome babies are babies below the age of 6 months. One is mortally afraid of KD occurring in the first half of infancy. So this baby had been running fever for several weeks. He had received a whole spectrum of antibiotics, oral, intravenous, what have you. When he reported, he had the typical features of KD in the form of conjunctival injection, a macular-papal rash, and BCG site reactivation. So whenever you have BCG site reactivation, there is virtually no differential diagnosis. So diagnosis was not difficult here. When we did the echocardiography, we found that the baby had huge coronary artery aneurysms. So he had an RCA aneurysm, which was 24 Z scores, a left anterior descending aneurysm, which was 60.8 Z scores. That again is not surprising because whenever you have delays in diagnosis in KD in early infancy, giant aneurysms are quite often there. So we started treatment, but we also did CT coronary angiography. So we are doing this procedure now much more frequently than previously. And the real surprise was when we did the CT coronary angiography. And this is what we found on CT coronary angiography. This is a dual source platform that we use in our institute. So this baby, in addition to the coronary aneurysms, also had involvement of the large vessels, the two main branches of the aorta. So systemic artery aneurysms in the context of coronary aneurysms in a small baby with Kawasaki disease. So systemic artery aneurysms occur in 1 to 2% of patients with Kawasaki disease, and they are especially more common in small babies with delays in diagnosis and who have already developed giant coronary aneurysms. So the lesson that we learned from this baby was, this was our first experience with systemic aneurysms in KD. The lesson that we learned was that when you diagnose giant aneurysms in a child with Kawasaki disease, the story does not end there. You should continue your search for systemic artery aneurysms as well. This was a 3-year-old girl whom we first saw in 2010. She had very severe Kawasaki disease. She was treated with intravenous immunoglobulin, but in spite of that, she had developed giant aneurysms, and she remained on long-term anticoagulation therapy as well as aspirin. At the age of 11 years, that means 8 years down the line, 8 years on follow-up, we did a CT coronary angiography. While the aneurysms had regressed, this child developed calcification of the coronary arteries. And this calcification was very, very prominent. So we have what we call calcium scoring index in children with KD. And based on this calcium scoring index, in this child of 11 years, this index corresponded to a chronological age of almost 78 years. What are the implications of this calcification are that should this child ever need a coronary intervention, angioplasty will not work. Bypass grafting is going to be a nightmare here. So what will be the long-term implications, we really don't know. But this is what KD can, the ravages of KD, what it can leave in the child. So these were dense calcifications of giant coronary aneurysms, even when the aneurysms had regressed in size. The fifth case is a 5-year-old boy who had Kawasaki disease. On echocardiography, the changes were not very impressive. He just had loss of tapering in the left anterior descending coronary artery. So the kind of changes which you just note and you hope that this will regress on follow-up, they often regress. However, we did CT coronary angiography on this child. And on CT coronary angiography, what he had was a giant aneurysm in the distal part of right coronary artery. Now, whenever there are aneurysms in the distal 1/3 or in the middle 1/3 of coronary arteries, these are often missed on echocardiography. You can't see them because the echo window does not permit you the luxury of looking at the distal part of coronary arteries. So this child had a giant aneurysm in the distal coronary arteries that had been missed not on one echo, but on several echoes. So this was the CT coronary angiography that we did in 2017. We repeated this recently, and this shows that the aneurysm is still persisting, and not only is it persisting, it has shown increase in dimensions. So we recently collated our data on distal coronary involvement in Kawasaki disease, and we published this based on our experience of CT coronary angiography on 176 children. Distal coronary artery involvement is a fact. It's a reality. And we drew an algorithm in this publication basically suggesting that 2D echocardiography is not enough when evaluating children with KD. You need to do CT coronary angiography much, much more frequently. The last patient that I have was a 4-year-old girl. Both parents happened to be doctors. And what was very disturbing was that one of the parents happened to be an alumnus of our own institute. Diagnosed to have Kawasaki disease in May 2013, diagnosed in time, treated by the pediatrician at that place in time. yet the girl developed giant aneurysms in left anterior descending and right coronary artery. Proximal LAD, the dimensions were 9.2 millimeters, which is a huge aneurysm. She had involvement of the distal LAD, RCA. So we did a CT coronary angiography in 2012 at that time, and it showed an eccentric filling defect in proximal LAD, which was diagnosed to be a thrombus. So this child remained on treatment with anticoagulation and aspirin. We recently called the child back and did cardiac MRI. So we have started doing, just begun doing MR angiography in patients with Kawasaki disease. And she was amongst the first few children on whom we did MR angiography. So 10 years down the line, there is still the aneurysms persist in both LMCA and the proximal LAD. The LAD thrombus also persists. But what was the most worrying part was the findings on late gadolinium enhancement. And this child showed late gadolinium enhancement here, which I'm told corresponds to zone 17 of the cardiac mapping on MRI. And this fibrosis basically means that this child had had a myocardial infarction sometime during the course of this disease. So myocardial infarction in a small child following Kawasaki disease. And not only is there myocardial infarction, but this area is thinned out. So that means there remains the risk of blowing out of this area of the myocardium in the form of a myocardial aneurysm or even a rupture. And this is what we picked on cardiac MRI, then done almost 10 years down the line. So cardiac MRI has been done in KD for almost 10 years now. It is useful in evaluation of the coronary artery lesions in all stages of KD, but especially on follow-up. Advantages that it has no radiation exposure, disadvantages that you can't do it in very small children because you need to sedate them. Interpretation of MR images in this condition requires a lot of experience and skill, but this is one way where you will pick up myocardial fibrosis, which is the correlate of a myocardial infarction in children with Kawasaki disease. So to conclude, KD is not a one-time disease of childhood. It can leave behind several sequelae. We became more aware of these sequelae ever since we started doing CT coronary angiography in around 2012, 2013. So we now have almost 9 years of experience. But I must reiterate that this is no ordinary angiography. Please do not expose these children to routine coronary angiography, CT coronary angiography, because the radiation that you would get through that will be unacceptable. So we use a 128 or a 386 slice dual source platform. There is only one radiologist who does this procedure. If he's on leave, the procedure is cancelled. It is very difficult to interpret because at that heart rate, you have to scan the child. It's not easy. It took him almost 18 months to master that technique. And we do it at a radiation exposure less than 1 millisievert. Perhaps the lowest radiation exposure anywhere in the world. So we have to develop these platforms. We have to develop the skills to do this amongst our radiologists. Only then should we go on to CT coronary angiography. And from whatever little we know about coronary MR angiography, there is much more to KD than just plain simple aneurysms. So patients with coronary artery abnormalities due to childhood KD remain at risk of cardiac complications throughout life. So I would end my talk by paying our tributes to Dr. Tomisaku Kawasaki, whom we lost in June 2020, just 3 months after the pandemic started at the age of 95. And what he has left behind is a disease that we still do not understand. Thank you very much. Thank you.
The next session for today is on gastroenterology by Dr. Ujjwal Poddar. The topic for today is inflammatory bowel diseases and intestinal TB, confusion to solution. We'd like to call upon Dr. Prashoti Acharya for introducing and presenting.
Good morning, everybody. It's a great honor today to invite Professor Ujjwal Poddar in the dais. With a brief introduction, we would start his talk, and after felicitation, Dr. Poddar, please come to the dais. Please have a seat. So everybody in this hall actually know Professor Ujjwal Poddar. I don't need to talk a lot about. If I want to talk, actually, it will take whole 15 minutes of his talk. So he is the pride and inspiration of Bengal, and he is a big name of pediatric gastroenterology in India. And he is one of the pioneer of pediatric gastroenterology in India, and he is the head of the department and professor in the Pediatric Gastroenterology Department of Sanjay Gandhi Institute of Pediatric Gastroenterology, Institute of Medical Sciences. So he's once again made us with number of publications. He made us proud again last year, where his name was featured among the 2% of researchers in the world as in the medical science faculty. So. And that was the list which is published by Stanford University. So it was a great, great honor. And today we are very proud to have him with us. So over to Professor Ujjwal Poddar for inflammatory bowel disease. Thank you, sir.
Thank you, Bhaswati, for your kind introduction. Good morning, everybody. At the onset, I must thank Apurva Da, not Dr. Apurva Ghosh. Apurva Da is Apurva Da, and his team of Institute of Child Health for giving me this opportunity. I have been asked to give the solution of this problem of tuberculosis versus Crohn's disease. So, what is the issue? Slide change. Okay. So, why are you confused? There is two disease. One is tuberculosis, another is Crohn's disease. But unfortunately, both of them mimics each other. The clinical, laboratory features, endoscopic feature, everything there is an overlap. In real life, it is many a times difficult to differentiate whether it is the intestinal tuberculosis and Crohn's. Now, when you are practicing in India, where tuberculosis is rampant, is an endemic disease. Crohn's disease number is also increasing. It is not that none of you have seen Crohn's. Probably many of you have seen Crohn's. So in real life, many times it is difficult to differentiate, And that's why I'm going to give you some idea that how to solve this maze. Now, I will take you through the real life journey of two cases to give some answer to this question, how to differentiate. Now, the first child, she was referred, one of you sitting in the audience, to me way back in 2014. She was a 7 years old girl from Habra, North Chobis Pargana. Now, she presented with 2 years history of streaks of blood in the stool. It is not that she was having bloody diarrhea. Mother says there is at the end of the defecation, there is streaks of blood. Sometimes she used to pass hard stools, suggesting there's a fissure. In addition, she was having general unwellness. She was having mild intermittent pain, anorexia, malaise over the last 2 years, but no history of fever. They said there's one of the family member had tuberculosis, probably lymph node received ATT 5 years back, but she didn't have any extra intestinal manifestation or no respiratory symptom either. On examination, she had anthropometric bang normal. There's 2 years history she was having of malaise and some pain and some seeking of blood. Her weight height normal, no pallor, no significant lymphadenopathy. Everything is systemic examination are normal, except that she had a deep fissure in the perianal region and a tag. So, what would be the diagnosis with this setting? She was having some kind of mild pain, anorexia, malaise, not much of growth failure, rectal bleeding. So these are the differential diagnoses you consider when there is a colonic involvement in addition to the systemic symptom. Crohn's disease, tuberculosis, maybe lymphoma, but the history is quite long, so we'll not consider. Immune deficiency, she didn't have any other features to suggest. So that we boil down to differentiating between the Crohn's and tuberculosis. We started investigating. If you see the panel of central blood count, hemogram, hemoglobin is normal, platelet normal, but she had some elevation of inflammatory markers, total protein albumin normal, a tuberculosis workup, including gastric aspirate, which is not mentioned here, Mantoux negative, X-ray negative, gene expert in the biopsy is also negative. Then we did the immunological workup, HIV and immunoglobulin panels are normal. So what next? Obviously, in this setting, we'll do top and tail, both upper GI, lower GI, and you need to see the small bowel as well by CT angiography. You see the colonoscopic picture. This child had absolutely bang normal rectum and most of the colon. That ascending colon, descending colon, transverse colon are absolutely normal. However, once you reach the cecum, we saw this ileocecal valve ulcer. There is a gaping ileocecal valve, and there is an ulcer in the ileum as well. CT angiography, unfortunately, normal. When you suspect Crohn's disease or tuberculosis, that gives a huge amount of information because small bowel needs to be evaluated. This child didn't have any significant lymphadenopathy to suggest tuberculosis, or there is no circumferential bowel wall thickening to suggest Crohn's disease. Upper GI endoscopy was normal. Got this biopsy done. Biopsy showed otherwise the colonic biopsies are normal, except that the area of ileocecal region there is a granulomas. But these are ill-formed granulomas, no caseation, AFP stain negative, gene expert negative. Upper GI endoscopy and biopsy normal. So what is the diagnosis? We thought this is the child who came from the rural background, middle class family. There is some history of contact with tuberculosis, though it is not clear, and localized disease to ileocecal region. Only the terminal ileum and the ileocecal valve was involved. Rest of the small bowel normal. Colonic biopsy bang normal, except that granuloma in that involved area, and CT scan is also normal. So why not this is tuberculosis? Let's give a trial of anti-tubercular drug. We started 4 drugs, followed by 3 drugs. At the end of 6 months, and we simultaneously started treating the anal fissure as well. Some subjective improvement. Mother said, yes, the streaks of blood has decreased from daily to now once a week. She gained 1 kilo, 3 centimeter height. Her blood parameters started improving. Hemoglobin improved from 10.5 to 12.5. Platelet count normal. Inflammatory markers borderline still elevated. Repeat colonoscopy, almost same picture. No deterioration of the disease, but no significant improvement. So we decided to extend the tubercular therapy by another 6 months. But at the end of 12 months, there is worsening now. Now she has started developing anorexia. She lost 1 kilo in last 6 months. Pain abdomen became more frequent and more streaking of blood. Blood parameter again going down. Hemoglobin, ESR, CRP is now significantly positive. Repeat colonoscopy, there is worsening of the features. And then at this point of time, we stopped ATT and started her on Crohn's therapy. This is the repeat colonoscopy after 1 year. What we have seen is a significant ulceration of the ileocecal area, deep linear ulcer, and those segments which are not involved initially, that ascending colon, transmuscular, they are also started having ulcer. So normally, if you get the multiple areas involvement, more chance of Crohn's disease. So we started the therapy with the steroid and azathioprine. In 3 months' time, she showed significant improvements. She gained 5 kilo weight. Her inflammatory markers started coming down. Hemoglobin started improving. So then we have this expected turn of event. Those people who are sitting here, they face this problem. Practicing in Bengal is different than practicing any other part of India. So we lost follow-up. Obviously, she stopped coming to Lucknow. I inquired after 1 year on phone. So usual story. I don't know why Hahnemann was born in Germany. Probably, ideally, he should have born in Bengal. In Germany, probably not many people follow homeopathy, but in Bengal, everybody follows homeopathy. And there is a denial. When you explain that this is a Crohn's disease, require almost lifelong treatment, so the parents denied. They said, no, it cannot be. So they stopped coming, they stopped therapy, and obviously there is all faith healers who will say that we have the cure. Why you are treating with for Crohn's? I will cure. Started homeopathy as expected. The disease relapse. So then another event, Dakshinatva Brahman. I don't know, probably all of you face this problem. So they lost all faith to Bengali doctors. I don't know, we are proud to be a Bengali. I am proud to be a Bengali, but somehow our patient population and the parents, they don't believe so. So they set out for a pilgrimage to the south, and I found out that this child is getting treatment in Asian Institute of Gastroenterology. Anyway, but the final diagnosis is Crohn's. This is not tuberculosis, despite having the features to suggest tuberculosis. The second case, this is a 15-year-old female, almost similar story, but she has a shorter history. 3 months history of significant pain abdomen, weight loss of 5 kilo in 3 months, and she was having fever for 1 month. But she didn't have any features to suggest intestinal obstruction, no diarrhea, no bleeding from rectal bleeding, no extraintestinal manifestation, no chest symptom. On examination, this girl has significant weight loss, which are wasting. The weight was just 29 kilo, height was preserved, and she had pallor, but no significant lymphadenopathy, and abdomen was normal. She didn't have any fissure or any anal tag. So again, the likely diagnosis, significant anorexia, pain, weight loss, and fever. We thought of Crohn's versus tuberculosis, but any of you suspect celiac disease in this patient? I don't think so. 3 months history of fever, pain abdomen, and weight loss. I don't think celiac in 15 years is a card. But however, this is a problem all over India. So somebody thought of celiac disease, started working up elsewhere. Hemoglobin was low, platelet count was high, probably part of inflammatory marker. Got a tissue transglutaminase done. Now this is another problem. If you ask for a test which is not required, you may be in trouble. So TTG came positive, but it was just at 24. 16 was the cutoff. IgA normal, and got the duodenal biopsy done, and that showed some kind of villus atrophy with giardia. So they thought of celiac disease, started this child on gluten-free diet. I don't think any of you will agree with this diagnosis. There is nothing to suggest celiac disease in this patient. So we started investigating. She didn't show any response to gluten-free diet. She had anemia. So all the inflammatory parameters are very high. Platelet high, CRP elevated, ESR elevated. Her total protein and albumin is very low. But tuberculosis workup came negative. Mantu test, gastric aspirate, chest X-ray, gene expert from biopsy is normal. And we did the immunoglobulin panel normal. TTG obviously was normal. This is not a celiac disease. And we investigated with our endoscopy and small bore. Now, see this colonoscopic picture, almost similar picture, ileocecal bulb. This is a all whole colon is normal except there is ulcer on the ileocecal bulb. There is a deep ulceration in the cecum, and in the ileum also we got some ulcer. CT enterography is very important in this patient. Should long segment stricture. It is long segment circumferential wall thickening. It is not a short, more than 3 centimeter involving the terminal ileum. In addition, there are multiple short segment thickening in the ileum and jejunum also. Though she had lymph node enlargement, big lymph nodes suggest tuberculosis. However, there is no characteristic features of caseation or calcification. Upper GI endoscopy is normal. This is the CT picture showing this long mural thickening and multiple short segment narrowing in the jejunum and ileum. Now, histopathology of this child, those segments which we usually take protocol biopsy from all segment of the colon, did show that there is a crypt distortion, cryptitis, means some chronicity, and there is some ill-formed epithelial cell granuloma in that area of ileocecal region. But AFB stain negative, gene expert negative, upper GI endoscopy and biopsy normal, no celiac disease. So, what is the diagnosis? Again, the dilemma is it tuberculosis or Crohn's? This child had pain abdomen, weight loss 5 kilo, fever, only localized disease to ileocecal region, but rest of the colon normal. However, we have investigated, we found that there is a crypt distortion, suggestive of chronicity. CT scan was significant, this is suggestive of Crohn's disease. So there is a dilemma, is it tuberculosis or Crohn's? But there is no direct evidence to say this is tuberculosis. We started anti-tuberculosis. Now, think about the previous child and this child. In 2 months' time, previous child at 6 months, we got some 1 kilo weight gain. But in 2 months' time, these girls showed dramatic response. She gained 7 kilo weight in 2 months' time. Hemoglobin improved from 7.4 to 12.5. All inflammatory parameters, which was very high, become normal. Albumin from 2 to 4, ESR was level, CRP became negative. So there is no ambiguity that this child did show response to or anti-tubercular therapy. At the end of 6 months, further improvement. So everything became normal, and then we did the repeat colonoscopy. At the end of 6 months, see, this is called mucosal healing. All those ulceration, everything has gone. IC valve is normal, except that there is some fibrosis, which is common. If you have a deep ulcer healed, there will be fibrosis, but no mucosal lesion at all. So this is we call the mucosal healing. Final diagnosis of tuberculosis. So total confusion. First case we thought of tuberculosis, turned out to be Crohn. Second case we thought of Crohn's disease because of CT was characteristic, turned out to be tuberculosis. So how to differentiate? So this is the table showing when you suspect TB, when you suspect Crohn's. If the patient is coming with a obstructive symptom, subacute intestinal obstruction, that is a feature suggestive of tuberculosis, not Crohn's disease. If you get the perianal disease, the first child did have perianal disease. So that was a subtle finding to suggest Crohn's disease, which is described but less common in tuberculosis. But when you do the colonoscopy, you see the type of ulcer, linear, serpiginous ulcer, Crohn's, but tuberculosis is circumferential ulcer, imaging showing stricture. Usually in tuberculosis, it is a short and fewer stricture, but very long segment involvement, multiple segment involvement, more than 3 segment involvement. These are the features suggestive of Crohn's disease. Histopathology, you can granuloma in both, tuberculosis and Crohn's both. But granuloma in Crohn's disease is usually ill form, small granuloma, and less often seen. Tuberculosis is a large confluent granuloma, and obviously if you get caseation or the AFP positivity, that will suggest tuberculosis, not the Crohn's disease. Now this is the study from our department. In children, we have to compare the Crohn's disease 23 with tuberculosis. Historically, if you get the diarrhea is common in both, but if you get the bloody diarrhea, blood in the stool suggests Crohn's disease than tuberculosis. If you have intestinal obstruction, more of a tuberculosis than Crohn's. Ascites, extraintestinal manifestation are seen. Ascites in Crohn's and extraintestinal in tuberculosis. Good morning, sir. Then if you see the type of involvement in colonoscopy, what I was insisting on, left colon involvement. If you get the ulcer, deep ulcer in the left side of the colon, sigmoid, descending colon, then it is more like a Crohn's rather than tuberculosis, but isolated involvement of ileocecal area or IC bulb is more often seen in Crohn's disease. And obviously the granuloma I have described this giant and confluent and with a caseation in tuberculosis than Crohn's disease. But let's put the data to our patient. First case had some blood in the stool, suggesting Crohn's disease. Weight loss, abdominal pain are seen in both Crohn's and tuberculosis. Fever was not there. She had some perineal disease, the fissure. So that probably indicating. But if you see the involvement of the disease by endoscopy, ileocecal valve, isolated ileocecal involvement suggests tuberculosis. Our patient had first child. Linear ulcer was there. Granuloma is ill-formed granuloma. It is not the confluent and giant granuloma, which suggests Crohn's, but ultimately it turned out to be the features of both TB and Crohn's. Second case, again, features are overlapping. She didn't have any blood in the stool. She had pain, she had weight loss, she had fever, which goes either way, Crohn's and tuberculosis. Localized disease suggests tuberculosis, but she had linear ulcer. But what was there in the second case is the CT scan. There's long segment structure, multiple segment involvement of Crohn's. So there is total confusion. We cannot predict that which one is TB, which one is Crohn by applying all this clinical, endoscopic, and radiological data. So when you say it is definitely tuberculosis, when you have a microbiological confirmation, that means you document by gene strain positivity, AFP culture, or the gene expert, or gastric aspirate, or you show the biopsy caseation, but altogether you may be able to definitely say it is tuberculosis 50% of the cases. The rest 50% it is difficult. That's why this ACF specific consensus statement on Crohn's disease said that when there is a no clear-cut picture, you have no uncertainty about diagnosis, give a short course trial, 8 to 12 weeks trial of anti-tubercular therapy to prevent the dissemination. Suppose this is tuberculosis and you are treating with immune modulator like steroid as a therapy, there will be dissemination. On the contrary, if it is a Crohn's and you are lingering on treating with ATT, then there is a risk of complication as well. And that has been documented that when the diagnosis was delayed of Crohn's disease by giving ATT trial for 6 months, 1 year, then those subset of patients, there's the increased risk of subsequent complication like stricture and need for surgery. So in an endemic country where tuberculosis is rampant and the proportion of intestinal tuberculosis and Crohn's disease tuberculosis will outnumber Crohn's. So many times, despite all our effort, it is difficult to differentiate. Then the solution is probably empirical trial. Now, this is an elegant study from All India Institute of Medical Sciences, though conducted in adults, but very impressive trial. They have the two trial segment. One is derivative cohort, that means the retrospective cohort of 287 patients, and the prospective validation cohort of 55. They have included proven Crohn's disease with intestinal tuberculosis subsequently turned out to be. And what they have done, they have given anti-tubercular trial in this subset of patients where there is an ambiguity about the diagnosis, and they have repeated colonoscopy at the end of the 6 to 12 months. Now, very interesting finding. Global symptomatic response was seen in 38% patient of Crohn's disease. In day-to-day practice, what you do, when you put a child on ATT, you want to see the response. Is this child gaining weight, fever has subsided, whether hemoglobin is improving, etc., etc. How often you do the test which were abnormal before? Less often. So that if you go by only symptomatic assessment, even the Crohn's disease patient can show response to ATT. However, on colonoscopy, they show just 5% cases there is a mucosal healing, but all tuberculosis patients show response. So they have given this algorithm. If you have an ambiguity, start ATT, but don't sit on it. Continuously monitor at 2 to 3 months. If there is no significant improvement, repeat the endoscopy and prove that this is not Crohn's. If there is a significant improvement, continue ATT for 6 months. At the end, again, you need to show mucosal healing to say, for definitely it is tuberculosis or Crohn's, like the second case. This is our trial from our institute. In the 43 children, we have done the same thing. When there is ambiguity, even ATT and repeat colonoscopy, see almost 50% of Crohn's disease ultimately turn out to be Crohn's, showed clinical response, but endoscopically, none of them show any mucosal healing. Contrary to the all 100% cases of tuberculosis, they showed mucosal healing. So if there is a doubt, you can give a trial, but don't sit on it, don't monitor only clinically. You need to document mucosal healing to say this is TB or Crohn's. To conclude, in a developing country like us, where tuberculosis is endemic, it is important to differentiate tuberculosis from Crohn's disease. However, due to lack of sensitive biomarker, we don't have a test which will say 100% tuberculosis. I show at the best you can get 50% discrimination power. Many a times you face this difficulty and diagnosis uncertain. In case of uncertain diagnosis, the empirical trial may be given. However, you need to monitor closely and repeat colonoscopy after 2 to 3 months when there is no response, or at the end of therapy to document mucosal healing to say this is TB or Crohn's. Thanks for your patience here.
The next section is of diagnosis. Before that, would kindly, sir, please accept this small token from us. Thank you so much. The next session is by Dr. Shobhit Devpujari on blood gases made easy. I would like to welcome sir on stage. And I would also like to welcome Dr. P. Shortcut. Please introduce the speaker. And Dr. Opishma Sharma, who is the chairperson for this session.
So, very pleasant good morning to all and happy Independence Day. So, I have the honor and the pleasure to introduce Dr. Satish Devpujari sir, who is the man with virtue and simplicity. Sir is one of the pioneers of the pediatric intensive care in India. He started the first founder chairman of the Vibrant Pediatric Intensive Care Society. More than that, sir is a physicist and has his interest in the human physiology and with his connection with the basic sciences like physics, chemistry, and mathematics. Bonding of respiratory system and its connection with the technology and artificial intelligence fascinates him. So you can see all the portfolios of Dr. Satish Devpujari sir. I'm not going details with this due to the lack of time. So he has a galaxy of achievements, but what I want to highlight is that the achievement of Dr. Satish Devpujari says what we cannot imagine. He has developed 12 apps regarding to the pediatric intensive care and pediatric emergency, and even they may be useful for the general pediatricians. These are the most downloaded apps all over the world. He has also as a good educator, he has developed some simulators for educating the undergraduate and the postgraduate students on mechanical ventilation and arterial blood gas analysis. And most fascinating part is that during COVID time, the few of the mindful, like-minded investors and the researchers, they combined and spearheaded the team, and they formed this foundation, the Satish Medinova, and they have founded the low-cost, high-end mechanical ventilation made in India. So they have made the 2 ventilators. One is the Prano Setu non-invasive ventilators and the Prano Vayu, the invasive ventilators. Sir has donated these ventilators to us across the many institutes across the country, and they are saving lives across the whole country. So it's a very big round of applause to Sir. And now this today's topic, I think the ABG will be known by Dr. Satish Devpujari sir. It is synonymous to Dr. Satish Devpujari sir, because he had made this complex thing so simple that even the general pediatrician can understand. So the topic the ABG is made easy. I think none other than Dr. Satish Devpujari sir can talk on this, and it will be very apt for him. Welcome, sir.
এখানে
I must thank Institute of Child Health, Dr. Ghosh, and my friend Agni and friends here. I have been in this institute years back and really gets fascinated with the simplicity and the amount of work that's getting done in this institute. My presentation today is to make ABG simple and playable. And I owe a lot of this to certain institutes of technology and software and hardware in our country. So as you can see here, I teach in the Government Medical College, but I'm also professor of mechanical engineering in BNIT and teach flow dynamics. And I learned so much of medical technology and medical devices from them that it really surprises me that today when regularly we are meeting the IITs, the amount of knowledge we have across the border is brilliant, surprising, and amazing. In fact, we need to change the border also to know as to how much they can help us. And a lot of these friends are ready to help in helping the medical field across. So I'll take you straight to how to make ABG simple. Very simple. You know, if you have an Android phone or an iPhone, download these apps. They are free. Go to Play Store or Apple Store and write Dev Pujari. And you will see all the apps that I have developed. They are used across the world. There's not a single country globally which is not using our apps. And I must accept the software industry has been a big help to me in developing these apps and making them available free. Yeah. So it is as simple as that. Download an ABG app, for example, ABG Complete. And this is the only app across the globe which is disease specific. You know, you will see apps which will give you metabolic acidosis, metabolic alkalosis, combined disorders and things like this. But there is no app which will diagnose RTA type 4. Or there is no app which will diagnose mineral cord excess, or an app which will diagnose laxative abuse. And all this can be done very easily by something like this. So let's say ABG Complete. It's a very simple app. You just need to key in pH. Like the green zone is a normal zone of ABG. If it is acidic, if someone's pH is 7.28, enter the CO2 value and you get the diagnosis. How was it achieved is our own algorithm, which is shown here. So if you want to know what worked behind, it is shown here. Now, if you want to go further, in this, you can press for extended ABG. But something I'll show you very, very interesting, and I would like you to focus on this is, say I'm moving CO2 and see how the bicarbonate is moving. Is it clear to you? Now you'll be surprised, bicarbonate is like a politician, can change one party to the other party without making any difference. And the most useless thing in blood gas is bicarb. Don't ever focus on bicarb. Don't even think of base excess base deficit. In today's world, they have no value, which is very clear. See the way it follows CO2. It just follows it.
You increase CO2 and bicarb increases, you decrease CO2 and bicarb decreases. So only two things can help you diagnose ABG, that is pH and PaCO2. Now, the only use of bicarb could be to know if your report is normal or there's some mechanical defect in that. So, if you put in CO2 and pH and if the bicarb is 30, if it is not 30, then error in your ABG report. So we have an intrinsic mechanism to know whether the ABG report is correct. And this is the only app across the globe which will check the technology and the intricacy of the report. So if you are here and if a patient has metabolic acidosis, you can press for extended ABG and key in the chloride levels and you can know the anion gap. And again, you play with this. I really want you to play with my ABG app. It has been an example of academic terrorism. This Henderson-Hasselbalch equation is a typical example people have been afraid of. See, the moment your chloride level goes down, your anion gap increases. So the fact you have wide anion gap means it is hypochloremic acidosis. The moment your chloride levels get corrected, the anion gap will correct. If you have hypoalbuminemia, you can reduce the level of albumin and you will get a corrected blood gas. Now, if your normal anion gap is there, you can key in urinary sodium. Say if it is 45, urine potassium is 6, chloride is 56. You have proximal RTA or GI loss. Please don't scratch your head. If you want to get on the academics, I'll show you how it can be done. But today is a world of algorithms. And I have one of its kind of called Algoman. If you have algorithm, you can use Algoman, draw an approach to a particular disease, and making an app out of it is peanuts. What you need to know is how to be precise in algorithmic thinking. So you could use this. Now suppose if you have metabolic alkalosis. Now see here, the green zone is the normal zone. If it is pH is alkaline, we say it becomes blue. And if you have metabolic alkalosis, you can put in urinary chloride. If it is less than 25, you have saline responsive alkalosis. Simple. Now you don't have to waste time in trying to know, should I give saline or should I not? If you have more than 40 urinary chlorides, you give urinary potassium. If your blood pressure is high, you have metabolic, you have mineralocorticoid excess. If it is low, you have Gitelman syndrome. And mind you, this is the only app which gives you a diagnosis of Gitelman syndrome or variants out of that. There's nothing like that which exists across the globe which would give you this diagnosis. Now, how was this possible is, see the algorithm. And my thinking has changed for the last 10 years when I started teaching the engineering division. Their thing is absolutely precise. A lot of people will say, medicine mein aisa nahi hota hai. You have to have ifs and buts, but I don't agree. Next 5 years, we'll have to have mathematical thinking. There's no question about it. I'm very sure. And we'll have to have the habit of thinking perfect with algorithms. So you can use this app. Is it simple? I mean, just get into two things. Enter CO2, enter pH, and your diagnosis is done. Is the report correct? Try and see bicarb 26. If it corresponds to the ABG report, your ABG report is correct, or there's an intrinsic fault with this. And some of these we are using, and the further ABG app, which will be coming in about a few months, would have an inbuilt AI. I already have a data of more than 2 lakh users across the globe. There's not a single country which is not using these apps. Unfortunately, even today, though our software industry has helped me and I could make these apps free, users in India are not even 10%. So, we must get to the habit of being very precise. Now, if you have done this and you want to know and read about ABG, world's first ABG book is what was created by us. And this is by an American software company. They helped me in developing this book. So this is complete, like, you have ABC of ABG, you want to know what the ABG is all about, go through it. If you want to know what the pH is, people teach us the relationship of pH and H1 concentration. This is it, play with it. And very interestingly, the relationship of pH and H1 concentration, which is always taught to us, is as not linear. I understood from my mechanical engineering colleagues, the Satish, it is linear 100%. I said, what makes you think that? And then I had this question in mind. If you draw the pH and H1 concentration on a logarithmic graph paper, you'll see it becomes linear. So my first introduction on this was when I wrote to them the linearity of this relationship. And so sometimes we have to just cross boundaries to talk to them, and a lot of benefit can be achieved. So, the so-called Anderson and Hasselbalch's equation is this. This is the equation which we have always learned. And I remember when I was in final years, when they started teaching me this equation, they said, no, nobody's going to ask questions. Just kabhi ek aadh baar aayega or forget about it. And that's where I took this challenge. I said, how can we not know? And I had this so-called Krida in mind. I said, no, this is something I have to make playable. So you just do this, key in the values, and play with this equation. So it will play every step to resolve the pH that would ultimately be reflected on this. So I've solved this equation for you step by step. So the ABG book is a fully dynamic book which talks of all the aspects of ABG, and there are very, very interesting things to learn. But the most important thing is this dynamic graph. This is one of its kind graph globally, which again you can play with. See the normal values I've drawn. You can see the pH and H1 concentration normal. Suppose you increase and decrease the CO2. See the red dot which is moving. Okay, now this was not an easy software. And a lot of fellows in the US were, Satish, why don't you patent this? Last 10 years, nobody could copy it, and I know that they'll not be able to copy, and free mein to koi nahi karega, for sure. So this was done by our software folks. I'm impressed with their ability, superb. And if we talk to them sometime, a lot of these apps can be developed in our country, and not many across the globe would be able to do this kind of things. So this is very unique to our ABG book. And this graph, you can play with it. Then this ABG tutor for all of you to use free. आप इसको share करो on WhatsApp or make a PPT slide, whatever. But as I've said, the best part is play with this so-called mathematics that exists in the ABG and electrolytes. I was helped by Dr. Lawrence Martin, the world's largest red book on ABG. He was very kind to discuss with me, and he was at my place 3 times a day, so that I owe a lot of understanding of this to Dr. Lawrence Martin. His book on all you need to know about blood gases is worth reading if you want to know the intricacies of blood gas. So this RG Blossom is an American company which helped me in developing world's first app on iWatch. So it's been last 6 years
This is the only complex app on iWatch and smartwatch which will diagnose your ABG diagnosis. You can tap on the watch, it can go to your consultant with a relevant diagnosis. Again, that also is free. So these are certain things, there can't be anything simpler than this. So first thing is, because you're afraid of this, you don't use it is not a question. Use, play and understand would be what my equation would be. One of the most other thing that you could use is this gradient. Again, this does not mean that they have to be used by an intensivist. You can see on what FiO2 patient is, key in the PaO2 values, and you will get the gradient. Now, this is one of the most important thing. When COVID came in, this was one of the largest used app across the globe. In fact, this app, if you put in the barometric pressure, can be used in transfer of patients at about 10,000 or 20,000. In fact, just about 7 days back, one patient was being transferred in Netherlands, about 30,000 feet above sea level, and they were using the app, and there was a difference. So they wrote to me, I said, you put a barometric pressure, then you'll know what corrected A gradient is. So this has a complete app which can be used at every level, even if it is 10,000 feet below sea level or above sea level, you'll be able to correct the gradient. But day in and day out, this is one app which will mathematically document how critical your patient is when it comes to say bronchiolitis or bronchial asthma or any of these things. So you could use these apps. And I have given the information of any of these. So you can see the mathematics underlying this, and all this can be seen here. You can read and go through that. So these are certain things which can be used. And of course, if you want to know whether your patient needs transfusion, a lot of often we think on hemoglobin, but don't talk of oxygen curve and the content of oxygen. So a lot depends on how much hemoglobin you have, and you can see the content written there. So it is where our decision making is made simple. And again, the information is right there. So you don't have to mug up, and this is a knee-jerk reaction. I mean, you have to put your head into these decision makings. And when it comes to precision, they're 200% precise. Interesting, a lot of fellows, not across the other side, but in India will ask me, Satish, what's the validity of this? This is hardcore mathematics. I've just made it simple, that's all. So there are age-old mathematical formulas which have been used. I've just made it simple. So there's no question of their validity. They're 200% accurate when it comes to that. When the curve shifts for certain various reasons, you can know the contents very well. So while this has been done, I'll just take you through as to how I was helped by my association with the technology side. And this is a very brief summary. The idea is, if I could motivate some of you, the Institute of Technology Calcutta is superb. In fact, every month I have a meeting with them, and they would be very happy to talk to you. So a couple of things which helped me, one of them was developing these apps. If you are interested in science, the app on Algorithm is the only app which will help you in developing an algorithm. So it could be any algorithm, and that could be so some of the world's best books are using my apps. Like this is one of the most largely used book on neural ventilation. Last few pages are dedicated to the apps developed by us in our country and available free. Courtesy the ability to develop algorithms and our brilliant software fellows who helped me this. So now after that we developed certain teaching simulators, and I've donated to a couple of AIMS. Like AIMS Nagpur is using them for teaching applied physiology, and these are very easy tools to teach students. And I've said we don't copy. There's no need to. There's so much of brilliance of country. The other thing that was very useful was MUHS developing this summer internship program, where 5 students from Bombay were posted at my place with VNIT to teach technology. And that was brilliant. These fellows were too energetic, wanted to know everything, and our VNIT was ready to teach them. The one thing that was my research with Bits Pilani was the sensor at the tip of the endotracheal tube, a nano sensor which cannot be seen by naked eye. This was my presentation in one of the world's largest conference, mechanical engineering in Texas. I was the only physician presenting that. And this sensor is at the tip of the ET tube, unlike the sensors proximally placed. So a lot of this was the help that I got from the technology side. India's first oxygen helmet was developed by me with IIT Bombay, funded by Thermax. When Italian countries stopped exporting these helmets, a lot of patients died, but we could be quick enough to develop, and this is in market. And when I say in market, I have no financial interest in any of these projects. It's purely an academic interest and the fact that we want to do something. So this is the only app, this is the only helmet across the globe, which is computer flow dynamics. And that's an area of my interest. That's what I teach in the engineering side, the flow dynamics, and that's an area which is extremely important for all of us. So then we went on to develop NIV, and NIV is the most complex machine. You must have seen a lot of fellows in India try to develop the ventilator. All of them were some associations. Ours is the only venture in the country which is from first nut and bolt to what it is 100% India. And I owe a lot to some of the brilliant brains in Pune and Bombay who developed this software for me. So this is Prana Setu. This is world's first transparent ventilator. So I presented this across the globe, and in the ISCCM last time, we showcased this machine. It needs a lot of guts to make things transparent. It's not very easy, you know, when you make it transparent, very particular, perfect and clean. So, and the other thing that you see is the smallest ventilator, and it has a lot of the functions. If I have time, I'll show you. But this is the transparent ventilator, which is a product of our own technology. And this machine has one of the most interesting technologies of mixing oxygen and air to get into a low-cost blender. So this machine, this is the augmented reality of how our machine works. And it basically has various technologies which are different than what every other machine has used. And we have not copied a percent of any of the machines across the globe. This is totally indigenized machine. So it works on our own technology, and it's more than about 250 ventilators have been used across the country and cost less than 1/3 of what is available. And this is the only NIV which we could combine high flow nasal cannula with all the NIV machines. There's nothing like this which exists. And this was a technology which we got from automobile industry, because one of our partners is a brilliant fellow in automobile industry. So mostly the other ISCCM conferences, we have showcased this machine. Now this is India's first calibrating device. Yeah, I'm finishing that. And this calibrates all the ventilators. So I dedicate this to my father and the team that I have a lot of this success to. Tejas Kshatriya is a person from Pune. He has about 50 US patents. And he is one of the first Indian to make a hybrid technology car. So this is Satej, our own group for developing technology for the challenges that we are faced with. Thank you. Thanks a lot.
Thank you, sir. I have asked Dr. Sharma, kindly please, Dr. Shobhi,
Just a few words to say about that.
more of a researcher, thinker, visionary rather than vision. Huge kind of one announcement that Satish has group has donated a ventilator to ICH. We have received the ventilator today itself. So, and I can also say that ventilator will be utilized at full extent for saving lives. Rohan is not there, we will also be instrumental in that. So, thank you, Satish, on behalf of ICH for the ventilator, which will be using to its full extent. Thank you.
Thank you, sir. The next session is the ovation ceremony. It is also a memorial ovation. Complex epilepsy children, challenges and solution by Dr. Brajesh Udani. And I would like to invite Dr. Austin Satyavatan on stage to introduce our respected speaker.
Introduction.
Start the session by felicitating Dr. Brajesh Udani.
It gives me great pleasure on this 75th Independence Day to introduce this year's KC Chaudhary oration speaker, Dr. Brajesh Udani. Dr. Udani is a well-known figure in India. He is a consultant pediatric neurologist at the PT Hinduja Hospital in Bombay, and has been working there for the last 20 years or so. He has several orations, publications to his credit, more than 85 papers. He has been the president of AOCN, the chairperson of the subsection of Indian Academy of Neurology at the present. Dr. Udani has several students in his hometown and other places. He has been running a fellowship program in pediatric neurology at the Hinduja Hospital, and his students are scattered not only all over in India, but also around the world. This is the most memorable conference that we had in 2018, ICNC, that was organized by him and his team. And I'm sure a lot of you did attend this conference. He's also a family person. He's a doting husband, a father, and more recently, there are more additions to his family, a doting father-in-law, and a grandfather as well. I welcome you to the city of Jaipur.
Now I would like to call on the stage Dr. Austin Bush to felicitate Dr. Brajesh Udani.
এটা দেখলে এটি থাকছে কন্টিনিউ, ওটা হচ্ছে না, আর এটা থেকে যাবে পরেরটা। ওকে, Matron finishing 25 metric. Which is this one.
Good morning, everybody. Should I say good afternoon? I'm at the outset, let me thank Apurva Ghosh for inviting me to this K.C. Chowdhury oration. I mean, it's a very big, prestigious event, and I'm honored to have it. Arijit, of course, a close friend of mine, and he's given me a nice, though he's made me a little old now. Still, it's interesting to see what he said. I was thinking of what to talk on, and I basically, 40% of my work is in epilepsy, 40–50%, and a lot of it is drug resistance epilepsy. So I thought that the thing which I'm most comfortable with, I'll talk on that, and that's complex epilepsy challenges and solutions. At the beginning, let me speak a little bit about Dr. Chowdhury. I'm sure all of you are more familiar than I am. This Institute of Child Health is obviously started by him. He was born in East Bengal, trained in medicine at the Presidency Medical College. And I always remember my father talking about the three doyens of pediatrics, Dr. Chowdhury, Dr. Achar, and Dr. Koilo from Bombay. And the other big achievement was, of course, starting the first independent journal in India, pediatrics. And this, of course, has a very high impact factor now, in fact, more than the other journals in this country. He founded the Indian Pediatric Society, and then he had served on a lot of committees, including WHO. Unfortunately, died in 1973. So it's my real honor to speak at his oration. So what is complex epilepsy? I think the main thing is to understand that one is, of course, drug-resistant epilepsy. And I'll just tell you what drug-resistant epilepsy means, but still the definition of that. But the other thing which also occupies a large part of complex epilepsy is epilepsy with significant neurological comorbidity. And very often these two go together, though not necessarily. So I think when you have epilepsy clinics which deal with complex epilepsy, this is the main patient population to deal with. So these are the old terms, which intractable, refractory, etc., which have now been abandoned. And you have the new definition, which is failure of adequate trials of two tolerated and appropriately chosen. So each important word has been highlighted and used anti-seizure schedules, either as monotherapy or polytherapy, to achieve sustained seizure freedom. And if treatment success is 3 times the longest inter-seizure interval, or at least 1 year, whatever is longer. So this was what is the cost of drug-resistant epilepsy? And they're huge costs. I mean, costs, if you are dealing with them, you realize the neurodevelopmental issues they have. They develop autism, they develop intellectual disability, learning disorders. There are significant ADHD, the most common problem which they have. And of course, they have to deal with polytherapies, so adverse effects, lots of emotional family disruption. In fact, high rates of divorce. Mother lands up with the child alone. And this is something which we face. And then, of course, you come to the economic burden. Because, unfortunately, we do not have most patients. They have to bear their own cost. Cost of new drugs is enormous. And therefore, this economic burden very often breaks families, puts them into below poverty. The last thing is SUDEP, sudden unexpected death in epileptic persons. And this, of course, is more common in adults. There's also something which we face in pediatrics, where suddenly patients who are drug-resistant die. Drug-resistant epilepsy is not really true drug resistance in many cases. So it's about 10–20%. With errors in diagnosis, non-epileptic events, I'm sure all of you know this. So I'm just going to show you some examples. This is, of course, one this will work. This is, of course, the typical syncope, where you have a patient who's getting a syncopal attack, vasovagal syncope or neurocardiogenic syncope, where he's having convulsions. So it can be easily mistaken for epilepsy. With this boy, every time he used to have this at school, and he used to, when he used to run, that's what happened. Treated as epilepsy for many years without any benefit. And then an ECG was done. And of course, the diagnosis is quite clear. He's got QT interval syndrome. So whenever you have anything happening with exertion, one must exclude this condition. So I think anybody who comes with a first episode of anything, please do at least an ECG, nothing else. This is a 6-year-old girl. resistant myoclonic epilepsy, initially normal head circumference, later microcephaly, and intellectually disabled. GLUT1 deficiency. With glucose from the blood doesn't enter into the CSF, at least 50% should enter, it doesn't. The lactate is low, and this leads to comes with epilepsy, it becomes movement disorders, but epilepsy, especially myoclonic and absence, the most common. This little girl, now 6, so she hasn't been treated. The only treatment really effective is the ketogenic diet. This is a 10-month-old epilepsy girl, drug-resistant epilepsy, but onset at 4 months. And after some drugs had stabilized, then at regression of milestones, the epilepsy came back, and genetics has helped us in this. This patient had atypical pyridoxine-dependent epilepsy. So when you have pyridoxine-dependent epilepsy, it doesn't have to come at birth. So essentially, it can come post-neonatal. It can be transiently responsive to anti-seizure drugs. And therefore, you should use pyridoxine in anybody who's got epilepsy before the age of 18 months. And of course, biotin as well. This is not a very old syndrome. Patient 6.5-year-old, autistic behavior, chronic epilepsy. Everything normal, MRI normal, karyotype, TMS, etc. And if you look at his sister, they look alike. She's just starting the disorder. She's got few features of autism, and she has occasional seizures. And this was the MRI. I just look at these globus pallidi in the 6-year-old. That's bright. And that's why you do MR spectroscopy, and you find that the creatine peak, which is the energy peak in the MR spectrum, is absent. You give creatine, the same stuff which these gym guys use, and the creatine comes up and they do much better. So all these are misdiagnosis of really, it may be a non-epileptic disorder, metabolic disorder or something, which can be mistaken. And you need specific treatment. So creatine definitely. Okay. Now, errors in management. This is the most common cause of pseudo-resistance. Wrong choice, using sodium channel blockers for Dravet syndrome, for example. Low doses. One of the things most of the people do is you start one drug, it doesn't work, you don't withdraw it. You continue a second drug, you add a second drug, doesn't work for a third drug. And you use it at low doses. And you continue ineffective AAD, so you get more side effects and no control. There's also irrational polytherapy, which I will talk about later. Formulation errors, you change from Tegretol to Zen, Zeptol, depending on which medical representative visited you. You will change blood levels and you might have problems. Paradoxical seizure worsening is a, carbamazepine, etc. I'm sure of you know this. But remember, recognizing the generalized seizures coming on in a patient for focal seizures, the first thing you should think of is this. And though we don't advocate drug levels very commonly in certain medications, you must do it. These are two studies, one from Trivandrum in 1999, our own study from 1993, which is published in Pediatrics, where we found that minor switching things, coming from polytherapy to monotherapy, increasing the dose, etc., you actually could get a lot of patients seizure-free, the whole thing improved. So minor changes can make a drug-resistant epilepsy a drug-responsive one. So what is this true drug-resistant epilepsy? And I've just mentioned all the things which are high-risk factors. Certain epilepsy syndromes, the spasms, explosive onset, high initial frequency, status epilepticus coming on. If your first anti-seizure drug doesn't work, you have to be worried, because usually patients who have drug responsive respond to the first drug. Neonatal seizures are another cause, because that can cause injury. That is a sign of injury to the brain. And structural injuries, especially perinatal injuries, of course, are very common. There is a lot of data on age of onset, but there are many patients who have early onset epilepsy still get controlled fairly easily. Benign epilepsies of infancy. We looked at our data, epileptic encephalopathy is 518 patients. West syndrome was the most common, many others, LGS, Dravet syndrome, we will talk about, and many other things. And the most common, actually, etiology was neonatal hypoglycemia, brain injury, something which we had described in 2008. So this perinatal stuff is the most important. This big group of cryptogenic, so to speak, where you don't have a cause, may be actually genetic disorders which have come up recently because of the use of genetic testing. And what is the spectrum of this, of neonatal hypoglycemia? You may have a retarded autistic kid with spasms and, longer duration hypoglycemic seizures at birth. Or you may have this young boy who's otherwise normal, looks like a benign epilepsy of childhood, but actually has the same history, except that the brief seizures. And in fact, has the same MRI, which you can see over here. Over here is paroxysmal mild nucleosis. Over here, it's a lot. So this is the kind of changes which occur in HPI, and you can get variable syndromes of that. And then you have this new group which has exploded on the horizon called developmental epileptic encephalopathies. So these are patients who often are genetically based or sometimes structural, where they are always having a problem of delayed development because of their primary genetic or structural problem. But then because of epilepsy itself, spasms, whatever, there's a huge amount of regression and something which can be reversed and recognized early. So these patients, you look at the genes. If you look at this, you get, I don't want to go into this field at all. A number of genes which have now been coming, which show these patients they have usually a slow development from the beginning, and then they develop a bad epilepsy. So let's look at one of the common ones, Dravet syndrome, seen by the SCN1A. I'm sure all of you know that. Comes like febrile seizures, but they're hemiclonic, they're prolonged. Later on, they develop photosensitive seizures, like this kid has. They have a period where they become very bad. And in fact, over time, the green represents the abnormal development which comes on over time. And you have to avoid sodium channel blockers. There are many treatments, but the ones we have available over here are valproate, clobazam, and topiramate. Abroad, there's fenfluramine, there's, ketogenic diet also is very interesting. Remember to tell your patients not to have hot baths, etc. Look at this one. This is the second one, where this patient had focal seizures. Looking to the left, having jerking of the left arm, and is migrating from the left to the right. And if you look at the EEG, it's going from the right side to the left side. And this patient has a SCN2A, so a different mutation. But this one, as opposed to SCN1A, responds to sodium channel blockers, but the first one gets worse with it. So you need to know these things. And both might, of course, they present differently, so you can suspect one another. But genetics has become a very important part of treatment. Precision medicine in developmental epileptic, I just listed them over here. Pyridoxine, SCN2A, SCN8A with sodium channel blockers work. The GLUT1 with the ketogenic diet works. The BRIN2A, the management works. So lots of different things have come up. Some are still not fully successful. It's still something to see. This you should know. In tuberous sclerosis, mTOR inhibitors. If you look at this is the mTOR pathway. So to make it simple, mTOR pathway helps us to grow. So if you have the mTOR pathway, it regulates cell growth. If it is hyperactivated, it will grow too much. And that's exactly what happens in many syndromes like TS, neurofibromatosis, etc. And in TS, because of that, you get tumors, because of these mutations in the TS genes allow mTOR hyperactivation. And that's why you get epilepsy. And of course, there are two mTOR inhibitors, everolimus and sirolimus. Sirolimus is easily available over here, not too expensive, can be used. This was a trial which showed significant benefit with high dose everolimus in patients with TS. Over time, the effects actually improved. This is the probability of improvement in using of everolimus or sirolimus. Everolimus is very expensive. Sirolimus is what I would suggest. Coming to spasms, we know that the two main treatments for spasms is steroids and vigabatrin. Now vigabatrin is available, there's no reason to use valproate, other things. People have used both together or separately. Both together, starting together, seems to be more efficacious than giving one individually. The diet also is very important in spasms. The super responder patients, so you must try this. And the others are all basically questionable treatment. So a survey in India showed that many people are using steroids, ACTH mainly, but even oral steroids. I remember oral steroids are used at 4 milligram or more per kilo, not at 2 milligram per kilo. And these patients do very, very well as the ACTH. And if you have a treatment lag, it delays your development. So in South, if for example, in the UK study, which was the most big study in this, if you were delaying treatment for even 1 week, your developmental scores went down, and you may actually develop retardation because of that. The treatment lag in Southeast Asia is very high, primarily because of under-recognition by parents and misdiagnosis by the primary physicians. So it's very important to treat spasms correctly. So what is drug resistance? Let's just go through the regular epilepsy. This is a patient, 309 patients followed up, who had their first seizure, and see what happens over time. This is a follow-up of almost 5 years. So seizure control is there in 70%. First drug controls in 60%. Not bad. And the second, third, and fourth have declining number of percentages. So by the time you come to the fourth drug, only 12% of the remaining patients, ones who are not controlled, will be controlled. So really a fraction. So obviously after some time, when you say drug resistant, there's no point in trying more drugs. And finally, this is of course a study from the Western world, only 8% were drug resistant and 12% by 10 years. So not more than 10-12% true resistance. What do we do? When you have, first of course, you treat the pseudo resistance to make sure everything is correct. And then you can use polytherapy. Many years ago, it wasn't being, now you can use, but you use what is called rational polytherapy with different mechanisms of action, adverse effects which are different, absence of deleterious drug interactions. Older drugs have these problems, the newer drugs don't. The concept of drug load is there. So if you give 2 drugs at a smaller dose, you probably have the same adverse effects as 1 drug at a higher dose with similar efficacy. So in fact, it's better to give 2 drugs in case the first drug fails, or maybe partly, if the first drug fails, remove it, start a second drug. If the first drug is partly effective, add a second. That's what the thing is. And of course, other things like seizure home videos, diaries, etc. to know what's happening. In complex epilepsy, neurodevelopmental disorders. What do you use? If you have behavior, don't use levetiracetam. I'm only going to give you 1 drug. Don't use levetiracetam. Prefer oxcarbazepine, lamotrigine, or valproate. If there's cognition problems, try and avoid propionate, but not necessarily always. And use lamotrigine. Lamotrigine is highly underused because people are scared because you're going to rash, but you can go slow. If you have sleep issues, don't use phenobarbital and benzodiazepines. Cerebral palsy, no benzodiazepines. You get monodruling, for example, nitrazepam, etc. can cause a lot of problems. What about the ketogenic diet? Most of you know this. It is effective in all seizure types. The best super responders are tuberous sclerosis, West syndrome, and the myoclonic atonic. Some of these myoclonic atonic may be actually GLUT1 deficiency. So it's the first line in GLUT1 and some other metabolic disorders, and it maintains control over the long term and improves. Most important thing is behavior, which is a problem in drug-resistant epilepsy, actually improves with the diet. And some people who don't get control, the parents insist, continue the diet because you become quiet. And then now recent things, less restrictive, needs close, all those things are there. But if you have a surgically remedial lesion, please remove that. don't go for the diet. If the patients don't agree, then you can try the diet. And this is the type of diets which you have. This is the normal diet. And you can see the carbohydrate is about 50%. The ketogenic diet is about 2% or whatever. And the other less restricted diets like modified Atkins diet, etc., is about 10%. So now the less restricted diets are being used more and more. Lots of studies from Delhi have shown this, that they have equal effects. Whether you use the classic diet, whether you use the modified Atkins, or whether you use the what is called the low glycemic diet, all seems to be similar kind of response. Then you come to surgery. Does it really work? Is there any evidence that it works? This is again from India. I've tried to take all studies from India because it applies to us maximum. And this is a superb study from AIMS, where they had surgical group and medical group of drug resistance. And they showed at the end of 1 year, the surgery group did much better. The medical therapy group almost did not get control. So really, the probability of improvement of seizure freedom is maximum in these surgical group. And there were lots of improvements in behavior, seizure severity, etc., but not so much in IQ. So if you have a low IQ, maybe in the younger age group, I think it may help. In the older age group, may not. So it's an effective tool. But before you think of surgery, when you think of surgery, drug-resistant epilepsy, or I said, just to make 1 point over here, if it is a infant regression, don't wait for 2 years. Do it earlier if there's a lesion which you can operate on. If you have unifocal focal epilepsy, lesional epilepsy, please fast track it. Send him to an evaluation center as fast as possible. This is what pediatricians should do. And you exclude certain syndromes. The most important one are two actually. One is atypical evolution of benign, which I just showed you, benign epilepsies, and of course, genetic disorders. So for example, this is a patient with Beck, and over time, 10-20% of Beck may actually worsen, may look drug resistant, but over time it will go away. So don't try and do surgery in these kinds of patients. And of course, the EEG will tell you whether it's a ESUS or electrical status and slow wave sleep. Lesions where you must do surgery early are all these: perinatal stroke, heavy megalensis, any structural problem which is congenital or which could be acquired like vascular encephalitis, focal hypoglycemic injury, or a tumor. See, all these things can be easily picked up by a good quality 1.5 MRI. You don't require a 3 Tesla MRI. But there are certain lesions where you require 3 Tesla, you require epilepsy protocol. And this is not just temporal frequencies. Like most people are just doing temporal lobe sequences. You write an epilepsy protocol, the radiologist will do a temporal lobe sequence. And is only useful in adults. In children, you have to have a 3D imaging, FLAIR and SPGRT1. And this is, you can see this patient, T2 looks normal. There's a, transmantle sign, and a very focal dysplasia over here, which is very difficult to pick up. And this is, of course, something which can be easily operated on. Surgeons are not keen to do anything in these kind of patients. Bilateral disease, and you can do palliative surgeries, colostomy, VNS, etc. But better to maybe do diet in this kind of cases. Use drugs like valproate and lamotrigine combinations rather than go for surgery straight away, because there's a lot of problem with surgery. Just look at this case, 2-month-old. You can see the right side is very big. We operated at the age of 2 months, and this is what is called a vertical hemispherotomy. We just disconnect the hemispheres. We don't remove anything. She had a few seizures on day 3 of surgery, so we had to reoperate. And how did we decide that? Because there was some degree of connection still left. We use this what is called diffusion tensor imaging, where you can find out that. And after that, she's controlled for the last 8 months. One thing about you must understand is semiology, how it looks, seizures, the change. This patient has ocular seizures. See that? Suddenly he gets it, then it stops. It's 2 minutes. This is spasms, and this is a focal seizure. I think this is not playing. The same patient came with a focal seizure later. So from spasms to ocular spasms to full-blown spasms to focal seizures. And we know this patient had a focal, this looks like a normal MRI, but there's some change over here. So a PET scan showed there was hypermetabolism. We did a SPECT scan to do the injection of the tracer during a seizure. You can see it brightens up on the left side. This is another patient where what you do is subtract the ictal and the interictal SPECT. So lots of things you can play around with to find out. The MRI looks normal. And you can also do things like MRI, PET, co-registration. I'm just telling you what is available in many centers in India. And I'm sure it's available in Calcutta as well. So these are patients who can be helped by early reference. And this is a patient of TS. Lesions are many, but because there was a big lesion and because the hypermetabolism was maximum over there, tuberous sclerosis, we operated. The kid is seizure free. You can do language, motor, function MRIs, which tells you which side the function. Suppose there's a lesion right in the motor cortex, and you want to know whether it's shifted, so you can do surgery. So all these are possible. And now DTI tells us, for example, this is a patient who on one side of the normal tracts of the corticospinal tract, is very atrophic on this side. This patient will do well. Well, this patient who has a big lesion on the left side, unfortunately, the corticospinal tract on that side is perfectly normal. So if you operate on this patient, it will cause a hemiparesis. So what happens on the long term to these patients who are not treated medically? So we did a study for one of my JJ hospital students, and we found that 55 patients who either refused surgery or could not do surgery were followed for 5 to 26 years. And one seizure in the last year was seen in almost 40%, and 75% in 25%. So essentially, most of them do well. So that's a good sign, even if you have a medical, as long as you treat it properly, there will be a remission of the epilepsy over time. So its outcome is favorable in about 2/3 of patients. So 1/3 of patients with epilepsy are drug resistant, many are pseudo. 2, drug resistance must be looked for. Is there a reason behind them? You have to do a systematic planned management. You just can't be giving drugs one after the other. And most important is early referral. If you're failing in the first AED, maybe second, don't go beyond that. Because then you have a problem. Your kid might become intellectually disabled. Thank you for your attention. It's one thing I do need. Thank you very much.
We would like to call Mr. Kunal Bhattacharya on stage. Mr. Kunal Bhattacharya. To introduce Mr. Kunal Bhattacharya, he is one of the leading architects of the country. To his credit, he has essentially architecture, medical, hospitals that we see today. And Mr. Bhattacharya is really involved in the new architecture that is the ICH building that is coming up in the license. So we would welcome Mr. Kunal Bhattacharya. Also, our administration.
I invite Dr. Jayaswal. Dr. Jayaswal is a child psychiatrist who trained in the Mass Bangalore and also from United Kingdom. Though his wish was to be a history chef, but he opted for another profession, and he has got smile to several young kids.
Committee with your state. Next up is a guest lecture session by Dr. I.P. I will request Dr. Jagdish Chaudhary to introduce the speaker.
Thank you. May I request Professor Samir to please come up to the dais. Now, trying to introduce Dr. Malekar is simply a comparison. Most of us know big things now, but still there are a few young colleagues who might need just a few words about Dr. Malekar. He has a long association with Yoga. I still remember the 2005 national picnic just across the street in Science City Auditorium. He delivered something else said, changing trends, a challenge in the ordinary trade. And he has recognized the 2000s. And today he will be speaking on competing with yourself. He is a meticulous person. I have seen closely him working when he was the chairperson of IIT Computer International after secretary became a member. And just plagiaristic permission from you, sir, I still remember his golden words that when you diagnose a child, you please write your diagnosis in the description, and that is the first step in rationalizing antibiotic therapy. With this, I would like to request sir to release the textbook of pediatric infectious diseases, where he has graciously contributed a chapter also. This is the third edition, and it's a pleasure for us to release the book by Professor Samir. You can get this copy, to see this copy, and the bookstore on the side, and also book for issue, and it will be delivered to you. So, thank you, sir. Thank you for releasing the book. And let's hear from you.
Well, thank you, the organizers, and especially Professor Apurva Ghosh, who asked me to talk of something that is very useful, but even beyond science. I was wondering what I should be talking about. And then I thought there are many, many things that possibly we have not learned in medical school. We have learned largely science, but as we know very well that science is still uncertain and changing all the time. And you need to update all the time. And even thereafter, we are not very certain. And this recent pandemic has shown how the whole world is ignorant about medical science. And I think that's why I thought he suggested I should talk something which is certainly useful. And therefore, I thought we must learn to compete with ourselves. And I will just take you through what I mean by that. I think we need a competition. There is no doubt at all, because then only we can kind of improve upon. And it really inspires us to improve our skill and performance. So there is no doubt that we need a competition. But if you compete with others, you become hostile, aggressive, often bitter, which itself chokes your performance. And I think this is important to know, that you don't have to compete with anybody else. But when you compete with yourself, and what is competing with yourself? Yesterday's you with today's you. And each day you see what better you could have done and what better you could do. And I think if you do that, you try to beat your last performance, and I think become better over time. And if that is so, then it's such a competition. What is most important is it is always you who wins. So you have a satisfaction of having won. And if you look at that, then then it is time that we all introspect and audit our own performance. After all, we are the sculptors of our own life. And if you look at that, then the question is, when you decide to compete with yourself, you have to choose your own way. And what does that really mean? The fact that you exist in life does not make life worse. And there has to be a purpose in life, something to dream and something to achieve. And I think each one of us must have that kind of a dream that you want to achieve. And if that is so, then only you have a desire to excel. And if with that, you set your goals in life and try to pursue them. What should we do as doctors? I thought we should first become health promoters rather than disease managers. Today we are all disease managers and we have forgotten what is health. In physics, we learned about light, but not darkness. Okay, because absence of light was darkness. And we learned about heat. We did not learn about cold. Absence of heat was cold. So we should have been learning more of health, and absence of health is disease. That's what we are focusing on. And I think this concept, yes, we need to learn diseases. We learn how to get rid of them. But the prima facie, we need to learn about the health itself. I think all of us must want to be a good doctor and not just great doctor. There is a thin line between good doctor and great doctor. Great doctor is admired for his knowledge. A good doctor is respected for his professional credibility. And I think that is the difference. Well, knowledge is so vast that you cannot just cope up with it at all. But you could try to be good. And I think that is where you need to focus what is your aim really is. I think we need to practice medicine as a profession and not as a business. Now, what's the difference between the two? Both want ultimately some monetary benefits. There is no doubt about it. But the business has that as the only motive. Whereas a medical profession should have a first motive of what best can be done to keep the person healthy and to relieve him of his discomfort. And the second side effect, if you like, should be the economic benefit. And I don't see any doctor in the country who is poor. So we should try to look at medicine as a profession. And I think in a business, you don't have to be qualified. In a profession, you need to be qualified. In business, you need not be updated. In profession, you have to keep on updating. In business, you ultimately count how much money you make. Whereas in profession, you count how much joy you got, how much blessings you got. And I think there is a vast difference between we practicing as a profession and not just as a business. I think finally we want to command professional credibility, peer acceptance, and I think a social respect. That is what ultimately we want. But finally, don't forget, we want to balance between professional work and personal life. In professional work itself, we need to have a lot of balance. For example, as a doctor, I must balance between science and art of medical practice. The art involves a lot many more empathy, communication, counseling, and so on and so forth. So in professional work, I have to balance between science and art. I have to balance between evidence-based medicine and experience-based medicine. After all, an evidence has come out of experience only. And today we know evidence is of different grades. And therefore, again, we need to balance between evidence and experience. We also need to balance between the modern science and a traditional wisdom. Because today modern science has almost proved what our ancestors knew was reasonably correct, but their language of communication was different. And today we can show evidence of what they knew. And I think this professional balance itself is important. But Finally, you have to balance profession with the personal life. And what is personal life? The personal health itself. I think majority of us ignore our health by feeling that we are so busy and our patient need us so badly. I think we need to look after our own health. We need to look after our family. How many of us can give time to our family? And then finally, in personal life, we have to really balance between time, energy, and money. As you start your medical practice fresh, you have enough time, you have enough energy, but you don't have enough money. When you develop practice and become busy, you have enough money, you have enough energy, and you have no time. And you come to my age, then I have enough time, I have enough money, and I have no energy. What a pity. I think this is where you need to balance between all that. Now, when you started practice, you didn't have money, you can't raise money. And at my age, I can't raise my energy. But at the middle age, when you had enough money and enough energy, why did you not use money? And why did you waste time in collecting money? After all, when you keep on collecting money, you lose thereafter for maintaining your own health. Why did you do all that? And I think this kind of a balance in our life is very important. And I think final aim of all of us, whether in medical profession or not, if really to achieve happiness and not mere success. In fact, to me, success lies in happiness only. Success is what others see. Others feel you are successful. You may not be happy internally. So really, you need to be happy more than successful. And I think success is defined by many authors in different ways. One author says success is somehow to get what you want at any cost. No, but the real success is you want what you get and you want what you need. That is success. But the best definition of success is by a person who wrote an excellent novel, a monk who sold his Ferrari, Robinson. And he defines success as an side effect of any act that you do for somebody else other than you. I think an excellent definition of success. And finally, happiness is what you feel. Success is what others see. You must know that your success lies in happiness. And I think if you focus, this is what I want to achieve, and I want to compete with myself, whether I can achieve this better and better. I can vouch that I have not achieved many of these things, but I'm aware that I could do a bit better than what I was yesterday. And I think that is what it is. How do you achieve all this? Now, if you really see, holistic care is what our ancestors have been talking about. And what is this holistic care? The nature has endowed upon human beings body, then heart, mind, and soul. We use all this in medical practice. What does body mean? The knowledge. We all assemble here to gain more and more knowledge. But what about heart? Compassion. So you have to use compassion also while you treat your patient, and not only the knowledge. And finally, the mind. And what does the mind mean? You commit to do your best. That is your mind. And finally, what is the soul? Inner conscience. Even if I fail, I must have a conscience of having done the best that I could do. After all, nobody is immortal. Every doctor is bound to see death, and every doctor is bound to fail. But at the end of the day, I should be happy and say, I did the best what I could have done. And I think that is holistic care. We all get information today at the click of the mouse. But knowledge is when that information is digested, absorbed, retained, and even practiced. Almost like a food. Just because you ate you did not get enough energy. It had to go through a lot of process. And therefore, today we don't want information, we want knowledge. And then wisdom is far further. Wisdom is to know when to apply knowledge and when not to apply knowledge, and where to apply knowledge. For example, we all know tomato is a fruit. That is certain. That is the knowledge. But what is the wisdom? Don't put it in a fruit salad. And that's why you will find that tomato being a fruit is sold by the vegetable vendors. Even they know that. How that is wisdom. And I think in medicine, we also try to achieve wisdom. It's extremely difficult. But if you know you have not achieved, and if you plan to achieve it, at least you will keep on trying it. Doesn't matter if you never achieve. And how do you do that? Detailed history. I realized Dr. Udane, Rajesh's father, told us how powerful the history and the physical examination is. Those days when there were no investigation, he knew much better than what the investigation would show, just by looking at the patient. And a thorough physical examination today, I'm sure the endocrinologists use growth charts all the time, but all of us must use the growth chart. And the growth chart tells me origin, duration, progress of each disease. How easy it is. Your assistant can do it. I was told by the endocrinologist, and that first week of their postgraduate training in super specialty was how to take height. Okay, it is so difficult to take correct height. We need not worry about that accuracy, but some growth chart, today we have a lecture on growth chart, some growth chart, some lines going up, but please chart it. And if you do that, if you don't attend to it, parents will ask you, sir, why these lines are going astray? How many of us can do that? I think the only difference between adult physician and pediatrician is we look after growing children, and the growth is the minimum you should do. And not even 5% have a growth chart in the country. We have Indian growth charts made by this man who is going to talk about the growth, Dr. Khadelkar. And even then we don't use it. It is available to download, even if we don't use it. If we use it, then we have a chart, but we don't chart it. If we chart it, we don't interpret it. So finally, 1% use the growth chart in general practice, and I bet it is the best way to know the origin, duration, progress. Okay, and I think these are important things. We must have a provisional diagnosis put down on paper. After all, provisional means that it is not certain. And unless you have a provisional diagnosis, you cannot decide which test to do. I know Dr. Khadelkar once mentioned that endocrinology without hormonal studies. And if you see tall and fat, don't waste time in hormonal studies. How easy it is for all pediatricians to understand. Even if I understand one bit of each of super specialty, I could be a good generalist. And therefore, a very rational test. And finally, I did say that we have to be health promoters and not disease managers. How many of us promote health? We give vaccines because it's economically beneficial for us. That's the only preventive measure we take. Forget the nutrition, forget the rest of it, hygiene, so many things about it. And I think that is important. Finally, the art of medicine, the ethics, the culture, communication, counseling, documentation. And I think all this is very, very important. But one thing that we must remember is whatever the parents come with the complaints of their children, they have many hidden symptoms which they don't even talk to the doctors. And what are those hidden symptoms? That one day fever in a child has a mother having a lot of hidden symptoms. She is anxious. She has a fear. With today COVID and flu, she is worried about. She is not certain what can happen. And I think, should we not be treating her hidden symptoms? How do we treat her hidden symptoms? That means we treat her mind. And how do we treat our mind? By the art of medical practice. Today it is known that each one of us, if I have to see what is the composition of an average human being, we are 30% genetic. Whatever today happened, it's genetic. And therefore we do genome sequencing. But what do we do thereafter? At present, we only know what happened, but we don't know why it happened. So 30% of us are genetic. Another 30% are phenotypes. So today, every disease has a different spectrum of presentation, phenotype. And what is remaining 40%? 40% is mind. And today we know that mind decides how quickly you heal or how completely you heal. And how do you address to the mind? You address to the mind by all these things. I think, do you need motivation to start competing with yourself? I think motivation decides what you do, but attitude decides how well you do, and attitude takes you to altitude. And if you look at attitude, if you give every alphabet a numerical number, A for 1 and B for 2, attitude is the only thing that gives you 100 as a total. So you can see how attitude is important. And I think we should not go by extrinsic motivation, which is reward, money, power, position, or even sometimes a threat or punishment, but it's an intrinsic motivation that resides in you. It comes from within you. And how do you get that intrinsic motivation? When you enjoy work, when there is a pleasure without expecting a reward, the reward follows, but you need to kind of enjoy that. It has a very positive impact on life. It makes you happy and healthy, so much so that you must try to die as young as possible, but as late as possible. And that is possible only if you do all that. I will just finally end up, during this pandemic, because of my age and because I had a severe illness, I was told not to step out of my house. And almost 1.5 years, I did not go out of my house. It gave me a lot of time to think what I had not learned and what I learned after starting practice. And that culminated into a book that will be published in the next 2 weeks. The title of the book is What Doctors Must Learn. We have not learned many things in medical school. And I think this book will be published by first week of September. It has 4 chapters. The first chapter is Doctors, You Look Beyond Science. And by that I mean beyond Western science also. There is a lot to learn from Ayurveda, for example. So we must look beyond science, and beyond science includes a lot of art as well. The second chapter deals with history is not his story, but much beyond. And you have a deliberate inquiry as a history. The third chapter is a power of observation, which I learned from senior Dr. Udane. He could just look at the child and start talking about the probable diagnosis, power of observation. And Rajesh tells me neurology is totally a power of observation. You need to touch the child to take a deep breath, and you need to go near the child to see the fundus. The rest is all by observation. Third chapter leads to power of observation, and the fourth chapter tells you you must test the tests before ordering the test. Thank you very much.
Please stand on stage and felicitate Dr. Bailey.
We all are familiar with fantastic drawings and paintings by Dr. Mancha. This is one more occasion where Dr. Mancha will be gifting one of his sketches to Dr. Bailey. Dr. Mancha.
Next up is Sachini Kumar Bose Memorial Race, which will be on Indian Folk Science and Economics, the past, present, and future, by Dr. Amal Kani.
Please. I request
doctors and friends, I'm delighted to be able to join you on this wonderful occasion on the 75th anniversary of Indian independence. And also to thank Dr. Bhaman Khadirkar for coming to Kolkata to deliver the Dr. Shishir Kumar Bose lecture this year. Since we are meeting on Independence Day, let me begin by saying a word about Dr. Shishir Kumar Bose's role in India's freedom struggle. When he was a young medical student, just 20 years old, his uncle, Subhash Chandra Bose, called him to his side and asked him a searching question. Amar ekta kaj korte parbe? And the work that he was assigned to do was to plan and execute Netaji's Mahanishkram, or the Great Escape from India. On the night of 16-17 January 1941, Shishir Kumar Bose drove his uncle from Calcutta all the way to Gomo station on the first leg of the Great Escape. And that represented the ascension of Subhash Chandra Bose to the status of India's Netaji, revered leader. Shishir Kumar Bose participated in Mahatma Gandhi's Quit India movement. He was imprisoned in Presidency Jail. And while he was home interned and had permission only to travel to medical college, Netaji's secret agents arrived and met him. He put them in touch with the revolutionaries of India, who were to organize an uprising inside India to coincide with the armed thrust of the Azad Hind Force. Once that work was discovered by the British, Dr. Shishir Kumar Bose was imprisoned in an underground cell of the Red Fort. He was then in solitary confinement for several months in the Lahore Fort, and finally in Lalpur jail before being released in September 1945. He returned to his medical studies and became one of independent India's leading pediatricians. He did his DCH at the Great Ormond Street Hospital in London and also trained in leading pediatric establishments in Sheffield, Vienna, and Bern. He married Krishna Bose in December 1955, and with my parents, as a 2-year-old, I traveled to Boston, where Dr. Shishir Kumar Bose had a Rockefeller Fellowship to engage in advanced training in pediatric radiology. He worked in the Children's Hospital of Boston with a wizard in the field of pediatric radiology, Dr. Ed Newhouser. And while he was a pioneer generally in the field of pediatrics, he was certainly the first specialist pediatric radiologist in India. He spent decades working at the Institute of Child Health. He was the director of the Institute from 1972 to 1992, and then he became president of the Trust of the Institute of Child Health. Krishna Bose was a founding trustee of the Institute of Child Health from 1955 onwards, and I'm honored to have been invited to join the trust of the Institute of Child Health. This afternoon, my younger brother, Professor Shumantra Bose, and I are both absolutely delighted to be here with you to listen to the Dr. Shishir Kumar Bose lecture to be delivered by Dr. Bhaman Khadilkar. Thank you very much for joining us today. Jai Hind.
Before we start the oration, we have to go I think to try to felicitate Dr. with his who is consistently a past friend of mine. He has served as the head of the Department of Pediatrics, really on the Institute for Medical Science. We salute Dr. for his contribution to the child.
Shushma represents stable children, which is an international NGO helping underprivileged children in the world. That's spread over 120 countries in the world. And ICI Stable Children has been our constant partner. They have created medical ventilators and many other equipments. Thank you.
May I request Dr. Hidayat?
Next on, will be organization road science and anthropomedicine, the last presentation by Dr. Bhaman Khadilkar. I will request Dr. Hidayat kindly introduce us.
So, good afternoon, delegates. For our next speaker, I don't think he needs a special introduction. He is one of the pioneers of pediatric endocrinology in India. The growth chart we use is from him. He was first president of Indian Society of Pediatric and Adolescent Endocrinology. Many IAP guidelines of growth, vitamin D, calcium is from him. He is author of many books and more than 170 publications, international publications. He is none other than Dr. Bhaman Khadilkar. You will welcome him. Thank you.
I will request Dr. Hidayat to kindly facilitate this.
Good afternoon. First of all, I'm extremely grateful for this honor, which is bestowed on me by the Institute of Child Health, Dr. Apurva Ghosh, all my seniors, colleagues and friends in the audience. It was interesting to listen to Dr. Shishir Kumar Bose's career from you, sir. And it's an interesting coincidence that I happen to be trained at Common Street Hospital in London. And also, we are in the process of developing a pediatric bone age atlas for Indian children. It was interesting that his interest also was pediatric radiology. So let me start. In the coming 20 minutes, 25 minutes or so, what I would like to do is to speak on what has been done for growth charts. And while I was asked to select a topic, I wonder what really I should be speaking on, because our major areas of interest include pediatric endocrinology, growth, bone metabolism, pediatric bone age assessment, and growth. But what actually is most relevant to any pediatrician in the world is growth, as Ambedkar sir just said. So let's move on to what is anthropometry. Anthropometry is the study of measurements and proportions of human body. And it's a branch of anthropology, which is the study of mankind, as you know. And today, let's look at it from an Indian perspective. So why do we study growth in children in the first place? Because it's the single most reliable parameter of health and disease in a child. Hence, it is also called as a road to health. So it's a road to health. And you just heard Ambedkar sir saying that we have to promote health. And to prevent disease, you must plot growth. So almost every pediatric and pediatric endocrine condition will have growth abnormality. It is very unusual to have a disease without a growth aberration. But to know what is abnormal, you must first know what is normal for your own country and for your own people. So when were the first modern growth charts in the world made? They were made in the 18th century by this French Count de Montbellard, who plotted his own son every 6 monthly on a simple graph paper. And as you can see, these graphs do not differ much from the charts that you and I use today. So human growth has a very deep-seated evolutionary basis. And it's a model which seems to have stood the test of at least several thousand years. Now, once again, a Bengali gentleman that we all might have forgotten, who actually has a significant contribution to Indian anthropometry. And he is none other than P.C. Mahalanobis, who actually made pioneering studies of anthropometry in India. And in fact, he founded the Statistical Institute of India, and he has been considered the father of modern statistics in India. He was also part of the first Indian Planning Commission. And what is astonishing is the Mahalanobis distance, which is used in statistics to test whether whatever new model you have designed aligns with the previous ones, is still called the Mahalanobis distance, and that 1946 paper still holds true even in today's medical literature. That is astonishing. So it has stood the test of time. Now, moving on, Professor David Morley, who worked a lot in the tropics and wrote pediatric priorities in the developing world, was the first gentleman to come up with parent-held growth charts. So even at the time, he realized that unless a parent brings a growth chart to the doctor and asks the doctor to update it, it is less likely that a busy pediatrician or a healthcare worker will do it on his or her own. So he introduced the concept of parent-held growth charts. Now, what was my interest and my passion in anthropometry? So while I was in the United Kingdom, I had the opportunity to work in Professor J.M. Tanner's unit. In fact, that's where I learned my pediatric endocrinology at Great Ormond Street Hospital. And indeed, the basis of my understanding of anthropometry and growth chart was laid down by Professor David Grant, Mike Priest, Richard Stanhope, and while I did an MSc at Great Ormond Street Hospital, Professor Tim Cole, who actually contributed to most of the growth chart development in the world, happened to be my teacher. And I was given a small project to produce ethnic-specific growth charts in Northwest Thames region of London. And after we had done them, we realized that there wasn't much difference between ethnicity. So when I returned to India in 1997, what were pediatricians using in India to monitor growth at the time? So there were ICMR charts, which were from 1960s, and they were Harvard charts. There were Agarwal tables. Professor K. N. Agarwal had not produced any charts. They were tables. There were CDC and British charts. But most commonly, as you heard from Sir, nothing. People were just not using anything. So this is what I found on various pediatricians' tables as I was surveying. And you could get almost anything that they could get their hands laid on. But the important thing is, the basic problem was there was a complete lack of uniformity. So there was a need for a uniform growth chart for India. Now in 1998, I made the first attempt to produce Indian charts using Professor K.N. Agarwal's data, and also started simultaneously collecting national data. And in 2007, the first IIP growth chart from Professor Agarwal's data were produced. Until that time, there were no IIP charts. In fact, as I said, Professor Agarwal had produced tables. There were no charts. And this is how they looked. In fact, the 2007 IIP guideline charts looked like this. Now you could look at it and say that, well, the lines are really sometimes they're kissing each other and sometimes they're deviating from each other far too much. So what was the reason for that? It was one of the very, very well documented study by Professor Agarwal. Then what was the problem? The problem was the statistical method that was used. So here we realized that the data already in 2007 was 20 years old. There was lack of smoothing. Centiles were not equidistant, and statistical methods were far too outdated to produce any modern chart. So preparing the IIP chart highlighted that we need to have more data. We need to have data on modern day Indian children. And we needed better methods of smoothing and better growth curves. And more importantly, we need to have easier growth charts to plot so that they can become popular. So in 2007 to 9, we actually made the modern Indian growth charts. Our team at Pune set out to collect data in all 5 zones of India, and it was a mammoth task. At every center, our team stayed for 15 days, and we collected samples on nearly 19,000 children, out of which 18,666 were eligible to be enrolled into the growth charts. And for the first time, we used the modern LMS method, the same method that has been used to produce WHO growth charts. And I must here acknowledge Professor Tim Cole's contribution to those growth charts, because he actually, I went to Great Ormond Street to make sure that whatever we had done was actually up to the mark. And that's our team at Jahangir Hospital who contributed to collection of data at all these centers. And this paper was written, the 2007 Affluent Indian Growth Charts. And what the growth charts look like was very similar to your IIP charts, but there was a difference. The difference was in the weight scale. If you look at the 97th percentile, it was going way above 100 kilos. And same for girls, they were also crossing 83 kilos. And at the time, the 75th percentile was actually crossing the overweight line. So even the 75th percentile, which we had recommended for diagnosing overweight, was also much too high. So this study clearly threw light on certain points, that children were taller, boys much more than girls. Children were much heavier, as heavy as American children in some parts of India. And simultaneously, Dr. Mawa and Tandon from All India Institute of Medical Sciences had produced their own charts, which also said the same thing. In fact, in their study, the 97th percentile was way above 110 kilos. So clearly, IIP's growth chart committee recommended that we need to produce weight and BMI charts which don't normalize obesity. So if you make growth charts on these very heavy children, you are going to call overweight and obese children as normal. So we ought to find a method of lowering the limit for BMI and weight. So around the same time, the World Health Organization recommended that adult BMI cutoff for Asian Indians should be 23 for overweight and 27 or 28 for obesity. So we then wrote this paper based on the very same data that we produced prescriptive, not descriptive, prescriptive BMI charts, which actually depicted 2 lines, the overweight cutting at 23 and obese at 28, which was later lowered further in the IIP group charts. Now, as the prevalence of obesity was really rising and metabolic syndrome was becoming more and more popular or commoner, the diagnosis was becoming popular and metabolic syndrome was becoming commoner. The metabolic syndrome's definition starts with waist circumference. And all that we were using at the time were the CDC waist circumference, which are way above the Indian children. So we wanted now to have waist circumference charts for our own country. So again, the same team produced, went out 5 zones of India, collected data on waist and wrist circumference at the time. And in the American Journal of Pediatrics, we wrote the paper on waist circumference percentile, 2 to 18-year-old Indian children. This was a multi-center study, and we produced these waist circumference charts. And here you can see that the danger line using the ROC analysis showed that the cutoff should be 70% and not 90th% as recommended earlier. So we have the charts for boys and girls waist circumference. Now, based on all this new data we had accumulated over a period of time, in 2015-14, the IIP Growth Chart Committee decided to come up with the IIP growth charts. And these are the growth charts which depict data on modern children. These growth charts are produced using the modern statistical method. Weight charts are produced in such a way that they do not normalize obesity in both weight and BMI charts. And also the aim was to simplify growth monitoring. But then for under 5 children, since Government of India had already recommended to use WHO growth charts, we only produce the growth charts for 5 to 18-year-old children, and 0 to 5-year-old, we maintain WHO growth charts. And this was the paper that, based on which the current growth charts that most of the pediatricians in India are now using. And what I would like to draw your attention to, that so far this paper has actually been cited by 296 publications. So it's a very highly cited paper in the recent times. So these were the growth charts which were produced that you use now, and the combined charts. So there's a slight blip at the junction of the WHO and IIP growth charts. And IIP also produced simplified WHO chart, because if you download the WHO growth chart, for every child you have 4 charts. And to plot 4 charts for every child, depending on the gender, there can be a lot of mistakes and confusion. So we added all 3 parameters on a single chart, which was length, weight, and head circumference. And on the flip side, we had weight for height charts, which are to diagnose overweight and obesity in young children. But the important question was, how applicable are the WHO under 5 charts? I mean, majority of you in your practice must have seen that 30 to 70% of all children that you see in India are below the WHO standards. So are they abnormal children? That's the question which is very germane in the production of next charts for Indian children. So we tested it in the field, and we found that even amongst the affluent children, this is the kind of Z scores that you get, that our children are much shorter, they're much lighter, but they're symmetrical. So we are just small, normal people, but we get stamped as abnormal because we are using the WHO standard. Majority of children that you find who are below the 3rd percentile on WHO weight and height charts are normal children. They do not have a chronic disease. The next question was height velocity. All these years, people were using Professor J.M. Tanner's height velocity charts. And I always had this question in mind, that we as pediatric endocrinologists tell patients that come puberty and your daughter will grow 22 centimeters. And if it's a son, then will grow 30 centimeters. But is that true in India? The answer is no. So we produce growth velocity charts by longitudinally studying 7 years of data across 3 places in India. And we produce the Indian height velocity percentiles, which was published in Indian Pediatrics in 2018. And as you can appreciate, the velocity curves for Indian children are much subdued as compared to the Western children. So based on the chart, come puberty, a girl in India would grow about 17 centimeters on average, boy about 25 centimeters on an average. Then we also went on to produce proportion charts for children because disproportionate short stature still gets referenced by the Western norms. So we now have produced 2 more papers, upper segment, lower segment ratios from birth to 18 years. This was in Indian Pediatrics, and I think this was in Annals of Human Biology, where we have produced sitting height and subischial leg length, which is far more scientific way of assessing proportions. But remember that unless the discrepancy between upper segment, lower segment is more than 2 standard deviations, it's not significant. So subtle differences are not significant. Then we produced extended IIP growth charts because in the pediatric endocrine community, there was a need, rather than calculating Z-score for every patient, if we could put 3 other Z-score lines. So we extended the lines to minus 2.25 for idiopathic short stature, minus 2.5 for small for gestational age infants, and minus 3 for severe short stature. And this was published in the European Journal of Pediatric Endocrinology and Metabolism, which are very helpful. So now the pediatric endocrinologists don't have to calculate Z-score each time, they can just refer to the chart. Now, as Sir said, popularizing chart is most important, and most pediatricians told me that they don't have the time to calculate either BMI or mid-parental height. So we then produced the pediatrician-friendly IIP charts in 2020, where we have now put 2 lookup tools. One is the BMI lookup tool, and other one is the mid-parental height lookup tool. And as you can see in this cartoon, if you have a kid who is 135 centimeters tall and weighs 30 kilos, she is normal. If she is 35 kilos, then she's overweight. If she's 45 kilos, she's obese. And if she's 20 kilos, she's underweight. So without any calculation whatsoever, you can now straight away screen a child who requires further investigations. And for mid-parental height, we have made it very simple. Just join mom's height with dad's height, and where it cuts at the middle line is the percentile, which is the mid-parental height. Then mid-arm circumference we all use for children to define malnutrition under 5 years. But then we thought, why not extend this approach to older children? For example, children who suffer from cancer. Can we now have a quick tool to tell whether the kid is malnourished, properly nourished, or overnourished? And this was a multi-center study and a lot of input from Tata Institute of Medical Research and McMaster University in Canada. And we produced this paper, I think, last year, where we now have extended the mid-arm circumference to children 5 to 18 years. And that's very useful. Like you can see here, these are the mid-arm circumference. These are twins, believe it or not. And this boy is here, mid-arm circumference, which is above the 27 equivalent of IIP. And the other kid who is much thinner, twin 2, has a BMI below 3rd percentile on IIP, and his MUSC is 16. So again, a quick screening tool where you don't have to calculate BMI. We have also gone on to produce disease-specific charts, and we have Indian Turner syndrome charts now, which were published in Indian Journal of Endocrinology and Metabolism. So far, this is what we have managed to do. These are the Indian norms that we have so far published. And in the last remaining 4 or 5 minutes, I'm going to talk about the future of growth charts. Now, as you can see, this is a mammoth exercise. You need to have a teamwork, you need to have funding, and children continue to grow. So your norms continue to change. So doing this exercise decade after decade after decade is almost impossible, especially in a country which is upwardly mobile in terms of its economics. So what is the growth chart future? They're going to be synthetic. Now, I'm going to spend a few minutes on what are synthetic charts. But as we saw, that this model of human growth had stood the test of time. It's an evolutionary, very robust model. So all children have a similar pattern to their growth, although it depends on their genes and environment. And populations do differ in height, weight, and BMI, but it's possible to synthesize anthropometry based on your local means by plugging it into a global model of growth. And this was first done by a gentleman called Michael Hermansen in 1999. And the same model can be extended further, as we wrote in our paper, that you do produce charts using his model and then use Priest-Benz or Jolly-Core model to fit it into a normal growth curve or to smoothen the percentile. So graphically, this is what you end up doing. You only need means of height and weight at these key ages. Now, why these key ages? Because populations of the world actually only differ amongst them at these key ages. So you take your own population's means at these 6 key ages. You don't need anything else. So then you can either use published data or you can use data in small pockets, which are representative, randomly selected. After you have got these points, then you derive the median. How do you derive the median? They are using regression equation based on a very large data set of more than 1 billion records of growth in children around the world over last 75-76 years from where the data is available. So you have the regression equation and then you smooth these means using Priest-Benz or Jolly-Core model. So you then have a graph of the median. And how do you extend it to percentiles? Height is a normally distributed variable. It has Gaussian distribution. So you can use standard deviation of adult height and the relative global standard deviation. But for weight and BMI, you have to have the global L and S values. I won't go into the details of the methodology, but using this equation, you can produce the percentiles. So we then tested this method against the standard method of LMS and wrote this paper in 2019. Indian growth references from 0 to 18 years, a comparison of 2 methods, LMS versus synthetic. And indeed, the medians are very similar, but at the extreme ends of percentile, synthetic growth charts actually score better because they are prescriptive. They depict a global model. So to my mind, the future of growth charts, which will be far more cost effective, is going to be synthetic growth charts. Now we have produced a lot of electronic applications to be used by people so that it becomes easier for them to plot growth charts. So IAP has its own growth chart application, which plots and interprets the growth for you. We have defined Microsoft Excel templates for anybody who wants to do research. Write to me, they're free of cost. All of these are free of cost. And you can get Indian anthropometric Z scores everywhere. So to summarize what I said, IIP 2015 charts are too representative of today's modern day Indian children for height, weight, and care has been taken not to normalize obesity. IIP 15 charts are prescriptive for the diagnosis of overweight and obesity. A large number of Indian norms, which I showed on that slide, have been produced and are available for clinical and research use. Caution needs to be exercised when using WHO growth charts in Indian, and most likely the future of growth charts may be synthetic, considering the difficulty in collecting the data and lack of ideal population in the world. There is no ideal population, so you will have to use synthetic method. Thank you.
So please accept this small token of gratitude from us. Next up is a section on precocious puberty and delayed puberty by Dr. Anurag Vajpayee. I would request Dr. Shomana Gundograni to kindly introduce this.
Good afternoon, everybody. Thank you, ICH, Dr. Abu sir, for considering me worthy of doing this honor. What an auspicious day to go one step ahead towards enlightenment. It has been wonderfully humbling to listen to all these stalwarts since morning. Dr. Anurag Vajpayee needs no introduction. I feel overwhelmed, proud, and extremely excited to introduce to you the iconic, illustrious pediatric endocrinologist of India, Dr. Anurag Vajpayee. And I feel overwhelmed not only because he's my guru, but because he's a true karma yogi. He's an epitome of positivity. He's the reason I'm here today. We all are here today, many of us sitting in the audience. Sir, for a person like Dr. Vajpayee, it's needless to say that he has got innumerable awards. He's the author of many books, many articles in index journals. He's a section editor of pediatric endocrinology in IJP. But I would be, it wouldn't be enough to describe who he actually is. He's a passionate teacher. He's a great teacher because he inspires many of us. He guides us. He's our mentor. Not only us, but people throughout India and also globally. His unique ways of teaching practical methods, algorithms, and his way of incorporating mobile technology in online education has revolutionized the teaching of pediatric endocrinology in India. I would request you to put your hands together to welcome the very iconic Dr. Anurag Vajpayee sir to the stage to enthrall us with the precocious puberty and delayed puberty topic. The stage is all yours. Welcome.
I would request Dr. to kindly face the person.
So precocious puberty and delayed puberty often we consider to be disorders which are pretty common, quite usual, with not much issues to evaluate and assess. I'll show you two cases as to why that presumption is wrong. This was an 11-year-old girl who presented to us with a final height which was achieved, not growing at all. And of course, this was a scenario because she had precocious puberty at 6 years of age and had gone to a practitioner who had just counseled that, okay, this is common, nothing to worry, things will go off. But by the time the child came to us, the bones were huge. So this is one scenario where we are missing pubertal disorders. What about the second scenario? We have got this girl who is concerned of delayed puberty at 13 years, which is just the cusp at which point you're worried about puberty, whether it's late or not. The parents were concerned because the child had stage 1 breast and pubic hair development. But what was really concerning was that the ultrasound was reported as an absent uterus. And this is a very, very devastating diagnosis. Now, what we need to remember is that if you do not have any breast development in a child, you don't have enough estrogen to produce in uterus. So if you do ultrasound there, you will falsely diagnose this as an absent uterus. And this clearly is a scenario we were messing out with that. So pubertal disorders are reasonably common. Around 2.5% will have precocious and 2.5% will have delayed puberty. Large number of them are physiological, but a substantial proportion is pathological. If you have a girl who has delayed puberty, and if you have a boy who has a precocious puberty, you have to specially worry about pathology. So your main concern is to not unnecessarily evaluate the physiological causes while not missing those disorders. But unfortunately, we are missing and messing as what we discussed here. Now, I'd like to thank the entire team of ICH for inviting me for this wonderful program. Dr. Apurva Ghosh, Dr. Joydeep, Dr. Hriday De, and Dr. Sumana for the kind words of introduction. So what we're going to do for the next 15 minutes or so is to go through entire spectrum of puberty. It's a very comprehensive topic, but we'll use case-based scenario to focus on that. All of you can go and have a look at our website, learning.growsociety.in, where there are a lot of informative courses, lectures, and videos which are available on pediatric endocrinology, including full 2-year hybrid fellowship in pediatric endocrinology and postgraduate courses with it. We have many publications which are covering the entirety of pediatric endocrinology, and we have developed our mobile application which provides comprehensive point-of-the-care validated care regarding different pediatric disorders. Just to summarize, for puberty, we have recently validated our puberty interpreter. Dr. Sayan, who is one of our fellows, has been part of this program. And what we did was that by using basic inputs, you would be able to identify the correct diagnosis. And what we did in the study was that there was around 95% concordance with what the app said than the actual diagnosis was. So not what we're going to talk here, it's now available easily in the app which you can use. Now, just to touch base about physiology, we all know that there are 3 organs which regulate puberty: the hypothalamus, which is the primary organ, the pituitary, and of course the gonads. And there are 3 groups of hormones: GnRH, gonadotrophins, and of course the sex steroids, which control the overall pubertal development. Now, if you have activation of any of these, you will have precocious puberty. In most of these cases, it is central. 95 to 98% precocious puberty in girls is central, around 60% in boys is central. And here you will have a LH level, which will be high. And remember, LH is the best marker as far as the pubertal onset and not FSH. If you want to follow precocious puberty, look at LH. If you want to follow delayed puberty, look at FSH. Now, here you will have large testes. And the most important part to look at in a boy with pubertal disorder is actually the testes. If you have precocious puberty with large testes, this is central. If you have precocious puberty with small testes, this is peripheral precocious puberty. This is what I will talk about subsequently. In girls, you will have a concordant pattern. You will have a breast development followed by menarche, typically 1 to 1.5 years. And this is what you will really identify in that scenario. You will usually have an idiopathic form, but you can also have organic pathology, particularly in girls who are younger than 6 years. The peripheral precocious puberty in boys is largely driven by adrenals in the form of congenital adrenal hyperplasia. And here the characteristic feature is small testes. So if you have a small testis precocious puberty, think CAH as a possibility in that regard. And in girls, if you have breast development and immediately you start having periods, start thinking about a peripheral form, a large ovarian cyst producing a lot of estrogen, some breast development, immediately having vaginal bleeding in that regard. Now, delayed puberty, on the other hand, can be because of a hypogonadotropic problem, which can be because of an organic cause, because of a functional cause, or any systemic illness. The hallmark there would be a low level of LH, which will tell you that this is a hypogonadotropic hypogonadism. Importantly, the most important thing to look at is a history of anosmia. If you have a child with delayed puberty and smell sensation is abnormal, this could be a hypogonadotropic hypogonadism because the migration of GnRH neuron and the olfactory neuron happens together, and therefore there will be a combined smell problem in that perspective as well. If, however, you have a problem in the testis or ovary, the characteristic would be a very high level of FSH, which will most classically be seen in either Turner syndrome or in the setting of a Klinefelter syndrome. So precocious puberty in girls, largely idiopathic central precocious puberty. Boys more likely to have an organic pathology. Peripheral precocious puberty in boys, typically CH is the most likely cause. While in delayed puberty in boys, PBGT is the most likely cause. In girls, Turner syndrome becomes a very, very important pathology in that regard. So we'll start one by one. So when do we call precocious puberty? So if you have any breast development or pubic hair development before 8 years of age, or you have a vaginal bleeding before 9.5 years of age, you will think that this is precocious puberty. Now remember, often obese girls may have lipomastia. So whenever you are talking about precocious puberty, palpate for the breast tissue. If you find no resistance between your thumb and index finger at the areolar region, this is classically lipomastia. Do not unnecessarily investigate in that scenario. Now, very importantly, LH is the best marker as far as puberty development is concerned. If your LH is about 0.2, it only means that you have entered puberty. Rarely you may need a GnRH stimulation test, which will be there in that scenario. But remember, LH of 0.2 is pubertal. So don't worry if it's more than 0.2. No need of any GnRH testing in that regard. Remember, you can have normal phenomena which may mimic puberty. Typically, neonatal puberty, which is because of passage of estrogen, lipomastia, which is not actually precocious puberty, and very importantly, in infancy, you can have 1 or 2 pubic hairs which may develop. This is usually in the labial region. No cause of concern. Do not do unnecessary workup in that regard. Now, precocious puberty can be complete, but often you have a girl who presents to you only with breast development. This will be an isolated form or a progressive form. And your role will be to identify whether it is isolated or progressive, and that will be very important in that scenario. If you have isolated pubarchy, think of an adrenal cause, CAH. And very importantly, if you have isolated vaginal bleeding, it is not an endocrine cause, it is trauma, tumor, abuse, foreign body. Think of gynecological cause. That becomes very important from that perspective.
This is a busy slide, don't worry about it. If you have puberty, the most important investigation is DHEAS. And remember one figure, if DHEAS is above 130, think of a pathological cause. Less than 130, adrenal. You won't need to do much in that scenario. If it's more than 130, 135, exclude CAS. That is a single message. If you have isolated vaginal bleeding, look for local cause. Refer to a gynecologist. This is not an endocrine. If you have a complete development, look at bone age. If your bone age is retarded, now everybody who has a precocious puberty should be tall with advanced bone age. If you have retarded growth and bone age, this is hypothyroidism. Basically, for practitioners, that's pretty much what you should think of. If your bone age is normal, don't worry. This is a slowly progressive puberty. You don't need to treat after 6 years of age. And finally, if it is advanced, in that setting, you look for LH, then decide whether it is central or peripheral. So look at the extent, look at the other parameters, and you will get the diagnosis there in that regard. We start cases, 3-year-old girl with hierarchy, 2-year-old onset 6 months ago, not progressing too much. There is no pubic hair growth, there is no periods. Now, what is you're looking at? Height is normal. So, what are the most likely diagnosis? This is classical presentation of isolated hierarchy, which is basically because of exaggerated mini-puberty. After birth, the hormones have a peak. Sometimes they may stay up 18 to 24 months as well. So this is our isolated hierarchy, and the flow would be a low LH. FSH may be high. Don't look at FSH if you're looking at precocious puberty. LH will be more important. So all you need to do is to follow. Nothing much to worry in that regard. Now, 6-year-old girl with hierarchy. This girl had hierarchy 1 month ago, but is quite tall. And her bone age is also advanced. So do you think this is normal? This is hierarchy with advanced bone age. You can't say it is normal, you have to evaluate it. So we have got this puberty interpreter, and you just enter the basic information, and it will give you the information that this is a progressive form of precocious puberty for which you would need to do evaluation and management in that perspective. 6-year-old girl with only puberty, bone height was normal, height is on the higher side, weight is normal, she has stage 3 pubic hair, breast staging 1. So this is isolated pubarchy or adrenarchy. The most important investigation here would be, so this is adrenals, you will look at DHEAS. So in this scenario, the DHEAS was high. So here you have to start thinking of a possibility of a CAH. So this is something which is very important from that perspective. 7-year-old girl with isolated vaginal bleeding, 1 episode, no breast development, no pubic hair development. So would you refer to an endocrinologist or to a gynecologist? This is clearly an isolated vaginal bleeding, non-endocrine, no breast, no uterus, as I already said. So this can't be an endocrine cause. Vaginal mucosa is red. Now, if your vaginal mucosa is red, it means that there is no estrogen exposure. If the vaginal mucosa is pale, it suggests that there could be exposure to estrogen in that scenario. And here again, you don't need to bother. This is isolated cause. It turned out to be a foreign body. So you have to send anybody with isolated vaginal bleeding to a gynecologist. Very interesting case. 7-year-old girl with hierarchy. 3 months ago, height is 100 centimeters. So you have a short child with precocious puberty, no pubic hair development, breast development is there, and you can see short child with precocious puberty. And there is a large ovarian cyst. So I think I've already told you this is enough clue. The diagnosis is short girl, delayed bone age, ovarian cyst, precocious puberty. Think of hypothyroidism. Every girl who has precocious puberty should be tall. If you have a short girl, think thyroid. That is important. Do not go for any surgical intervention. Don't refer to gynecologist because they will do a surgery here. Refer to an endocrinologist. They will give thyroxine, which I will. You need to know where should you refer, at what point. If bone age is delayed, this is hypothyroidism. This will improve. Now, how do you manage? Now, any girl who has puberty onset before 6 years of age or between 6 to 8 years of age with advanced bone age, you have to think of treatment. If it's central, what you do is to use a GnRH analog, which is basically going to separate the level of puberty. It is going to give you time to grow,
And typically we treat up to 10 to 11 years to achieve a good outcome. Important message here is that you will not have any effect on pubarchy because pubarchy is happening from adrenals. You just give GnRH analog for that. For peripheral forms, you can use medroxyprogesterone, but it is not going to help you as far as height is concerned, and it is bad as far as bone is concerned in that regard. So only if you are concerned about vaginal bleeding, like somebody who has a cerebral palsy and you are worried about that, there you can use medroxyprogesterone in that regard. What about precocious puberty in boys? It is defined by pubarchy or a testicular volume more than 4 ml before the age of 9 years. So if you have that, you have to be really worried in that perspective. So if you have precocious puberty in a boy, you have to be really worried about, because there is a higher chance of a pathological cause in that scenario, and that's important from that perspective. The most important thing to look at in a boy with precocious puberty is the testicular volume. If the testes are large, this is central precocious puberty. If the testes are small, this is peripheral precocious puberty. If the testes are intermediate in size, which means only the latent cells are functional, the other cells are not there, this is a HCG-driven scenario. And finally, if you have a unilateral enlargement in testes, this is like a testicular tumor. So testicular examination is the most important thing to look at in a boy who has precocious puberty. Now we have a 4-year-old boy with precocious puberty. What do you think is the testicular volume? It seems to be less or more. Difficult to assess, but definitely the testis seems to be enlarged. So this is classically a central precocious puberty. And if you have such early onset, you have to think about a central pathology. And LH was high. MRI was done, which showed this lesion, which is known as hypothalamic hematoma. Now, this is a benign condition. You don't need to refer to neurosurgery because they will maybe opt for surgery. This is a benign condition, a normal tissue in an abnormal area. No need for intervention. You may need to just give GnRH analog, with which there will be improvement. 7-year-old boy with precocious puberty, and what you see, there is a discrepancy in the penile growth and the testicular volume. The penis is enlarged, but the testicular volume is not. So what it means, it is a peripheral precocious puberty. And if you look at the testosterone levels are high, but LH is 0. So in that scenario, you do adrenal imaging, you find hyperplasia, and 17-OHP levels were very high. So if you have small testes, high testosterone, low LH, do a 17-OHP and you can identify that this is a congenital adrenal hyperplasia, and this is something which is very, very important. Very interesting case, 5-year-old boy with early puberty. Now here the testicular volume are intermediate. They are not very small as CAH, not as large as central precocious puberty, but LH is low. So you have an intermediate size testis. If you remember that slide, this means that the HCG is working, LH is working, but FSH is not. So what is there? This is a HCG producing tumor. If you have a low LH and your 17-OHP is normal, go for HCG. The levels are high, and this could be a tumor in the chest, in the abdomen, or in the brain. So this happened to be a germinoma, which was sitting up there. So if you have intermediate testis, low LH, high testosterone, do a HCG, rule out a HCG producing tumor in that regard. Now we have talked a lot about precocious puberty. What about delayed puberty? Now delayed puberty in girls is defined by lack of thelarchy by 13 years and no menarche within 5 years of period. So both onset and progress, both are important in terms of precocious puberty. Now, very important, the most important thing to look at in a girl with delayed puberty is pubic hair. If you have no breast development, but pubic hair is there, it means adrenals are working. This is a GnRH problem, a central problem. If you have no breast, no pubic hair, it means every growth is defective. This is constitutional delay of puberty and growth, or it could be a severe illness which is causing the problem. If, however, you have got good breast development and no pubic hair development, what does it mean? Estrogen is there, but androgens are not there. So this is androgen insensitivity syndrome. And finally, we've got good breast, good pubic hair, but no periods. What it means? You don't have any uterus. So if you just look at breast and pubic hair, you can make a diagnosis very easily in regards to delayed puberty in that perspective. Now, workup, always look at a common causes which have to be excluded. Look at FSH. High FSH, of course, you have to go for karyotype. Low FSH, you have to think of a central cause in that regard. So FSH is the main investigation as far as delayed puberty is concerned. So 16-year-old girl with delayed puberty, no breast, no pubic hair, short girl, LH is low. Now I said no breast, no pubic hair. It means CDG, constitutional delay. This girl is short also in that scenario. She had anemia, she had clubbing. So what would you think of? Short girl, anemia, clubbing, GI symptoms, no pubic hair, no breast development. TTG would be the most important investigation, which was strongly positive. So this was celiac disease. Always look at systemic causes before you go for anything else. 12-year-old girl, we all know the diagnosis, wide carrying angle. There is a short neck, low posterior hairline. So this is classically Turner syndrome. Investigations done showed high FSH. And everybody stopped there, didn't go any further. For the advised growth hormone, but unfortunately, few years later presented with abdominal lump and was found to have a Y cell line. So if you diagnose Turner, it is your duty to do a karyotype, because if you just go for FSH, you would not be able to identify the right diagnosis in that scenario. 16-year-old girl with primary amenorrhea, stage 4 breast development, no pubic hair development. I'll take just a couple of minutes. Is it okay? 2 minutes, yeah. So stage 4 breast development, no pubic hair development. Height is tall. So tall girl, stage 4 breast, no pubic hair. Where are we looking at? High FSH, high LH. What karyotype do you expect here? So I said good breast, no pubic hair. You have high estrogen, androgens are not working. So this is androgen insensitivity syndrome, and you will have a XY which will be there in that regard. So this is the androgen insensitivity syndrome which you're looking at, and our app will give you the diagnosis in that regard. Finally, 2 minutes on delayed puberty in boys, quite simple. But you remember, if you have no testicular enlargement by 14 years, that's delayed puberty. Do not go for pubic hair development or penile size, because that is difficult to assess in that regard. Again, pubic hair and testis will give you the diagnosis. If you have small, soft testis, less than 1 ml, GnRH deficiency. If you have 2 to 3 ml testis with no pubic hair, this is constitutional delay of puberty and growth. If you have large testes with no pubic hair, this is hypothyroidism, a very interesting scenario. And if you have a testis which is not very large, but you have got pubic hair development, there is a discordance that is because of obesity. So again, pubic hair and testicular volume will give you the clue in that regards. Approach looks complicated. I'll make it very simple. Always do the screening test. Look at gonadotrophins. If they are high, think of Klinefelter. Go for karyotype. That is a very important. If your LH is low, your question is it constitutional delay or is it permanent HH? So if you have anosmia, synkinesia, permanent feature, this is HH. If you have short stature, no pubarchy, this is CDGP. The most important investigation here is inhibin B. And if inhibin B is high, this is constitutional delay. If it's low, it is basically a situation of CDGP. 16-year-old boy with puberty concern, onset 13 years, stopped for 2 years, testicular volume is 3 ml, pubic hair stage 3, tall child, diagnosis CDGP. Do you agree? Now, 80% boys have CDGP, but pointers against CDGP are that if you have puberty, if you have a normal growth, if you have a stalled puberty, or if you have a neurological feature, it is not CDGP. So don't label every boy as a CDGP. He turned out to have a large craniopharyngeal part. So tall child, normal pubic hair, and development, this is clearly not a case of CDGP. Last case, 17-year-old boy with puberty concern, onset at 12 years, stopped for 3 years, firm testis with gynecomastia, very tall. Diagnosis, opposite of Turner syndrome. In Turner syndrome, you have got one Shock's nest, so you are short. Here you are tall, this is Klinefelter syndrome. Firm testis, gynecomastia, this is Klinefelter syndrome in that regard. So I think we'll stop at that point of time. Thanks everybody for patient hearing. And all of you can go and have a look. All the videos and recordings are available on our website. Thank you. Pardon? Prolactin? Yes. So prolactin is basically required if you have hypogonadotrophic hyperthyroidism and you want to achieve a functional or hyperprolactin.